Wel, bore da, ac pleser gyda i ddechrau heddiw ydy croesawu pob un ohonych chi i'r cyfarfod hwn, sef cyfarfod bwrdd iechyd addysgu Powys. It's a great pleasure this morning to be able to welcome each and every one of you, colleagues around this table, to this meeting of the board of Powys Teaching Health Board, and indeed to welcome those who are viewing our meeting online, or those who may view a recording of this meeting that will be available on our website following today. Cael cwprdwi cadeirydd y bwrdd iechyd, ac yn eich papurau ar gyfer y cyfarfod heddiw, mi welwch chi enwau yr aelodau, annibynnol a'r aelodau gweithredol sydd yn gwneud i fyny aelodaeth y bwrdd, ynghyd â'r rhai sy'n methu bod gyda ni heddiw ac sydd wedi cyfleu eu ymddiheuriadau am absenoldeb. Among the papers for today's meeting, which are available on our website, you have information about board members and the colleagues around this table, as well as those colleagues who aren't able to be with us today and have sent in their apologies for absence. Just a brief word about us as a board and our purpose and responsibilities. Ni ydi corff llywodraethol y sefydliad y bwrdd iechyd, ac fel bwrdd, dyn ni'n gyfrifol am sawl peth, yn benodol am osod cyfeiriad strategol y bwrdd, am liwio a siapio diwylliant y sefydliad, am osod arffaith risg ar gyfer y sefydliad, ac am fonitro perfformiad y sefydliad. We have a number of responsibilities as a board. The high-level responsibilities are essentially around setting the strategic direction for the organisation, setting the risk appetite and monitoring risk in relation to those strategic aims and priorities, monitoring performance of the organisation against those strategies and plans, and very importantly, setting, embedding, modelling and shaping the culture and tone of our organisation. Wy'n hapus iawn heddiw i ddweud mai dyma'r tro cyntaf i ni gwrdd wyneb yn wyneb ers cyn Covid. As you will see, we're all together in this boardroom today, and this is the first face-to-face meeting of the board since before the Covid pandemic. So I'm really pleased that it's now possible for us to be together in the same room and have that face-to-face contact, notwithstanding the great benefits, of course, that we've all learnt and that have come our way through virtual meetings and through operating remotely. But it really is good to be here today. Mae heddiw yn gyfarfod sydd yn cynnal yn gyhoeddus, ond jyst i esbonio, dydy o ddim yn gyfarfod cyhoeddus fel petai. We're meeting today in public, in line with NHS regulations, but I think it's important just to explain that there is a distinction between meeting in public and this not being a public meeting. So the only participants in the meeting are members of the board. However, we do always have a standing item on our agenda that invites questions from the public to us for consideration in our meetings. As it happens, we haven't received any questions for this particular meeting. So when we come to that item, it's simply a matter of noting that we don't have any such questions for consideration today. The last thing I want to say, just in terms of introductory comments, is that today is the last board meeting for Stephen Powell, our Executive Director of Planning, Performance and Commissioning, and Joy Garfitt, our Interim Director of Operations, Community and Mental Health. Joy can't be with us today, but it's really good, as always, to have Steve with us. I know, Steve, that we will still see you at various things before you leave, but just in this context, I just want to say a huge thank you for your impressive contribution and for the pleasure it's been to work with you. And I know that we will have other opportunities to thank you and wish you well. But thank you for that. And we will, as we go through our meeting, have breaks at various points, and those will appear as a slide on the screen for those watching. Felly, dyna diwedd y sylwadau cychwynnol, a dwi am symud ymlaen rwan at yr agenda go iawn fel petai, ac at item 1.1. Item 1.1 on our agenda notes the apologies and those who are in attendance today. Are there any declarations of interest from any colleagues in association with any item on our agenda today? No? And so we come then to the board action log. Helen, would you like to take us through this and just make sure that everything's covered off?
Yeah, pleasure, Carl. Thank you. Morning, everybody. Helen Bushell, Director of Corporate Governance and Board Secretary. So there are 4 actions on the board action log, 2 of which are on track and not yet due until the November and January meeting of the board, retrospectively. 2 are recommended to be completed, as you can see at the bottom of the page there. 1 was in context of the assurance reports of the board committees, and that was to review the escalated items. That's been included in the cover paper and reviewed by the committee. The other one was the corporate risk register and a request to review the risk level of risk 6 in relation to workforce specifically. That is also included on the agenda and addressed in that cover report, which we'll pick up later.
Does anyone have any questions or comments in relation to the action log? No? Then item 1.4, we don't actually have an experience story today. Circumstances were such that the production of that story and those stories wasn't possible for today's meeting. However, as we'll see later on in our meeting, we do have a presentation on planned care. Not the same thing, I know, but nonetheless a very important area of experience and operation that we will be looking at in a bit more detail later in the agenda. And so we've already dealt with item 1.5 in that there are no questions from the public. And so we move to item 1.6, to the update reports, and initially my chair's report, which I'll take as read, but I'm very happy to discuss any aspect of the report, receive questions, or enter into conversation. Please, Robert.
Thank you, Chair. Robert Lewis, independent member. I noticed that we're awaiting a response from the Cabinet's Secretary. Should we need to make alterations in service to accommodate a new financial envelope, how challenging is that going to be, bearing in mind we're already halfway through the year and that the consultations procedures are so extensive?
Thank you, Robert. I think, I mean, we will come later on our agenda to the finance report and so on, and there will be opportunity to discuss. But I just wonder whether Hayley or Pete might like to respond to that question.
Yeah, I'll start if you like.
That's fine. You have to comment.
Yeah, I think two things really, Robert. I think that clearly our position is to deliver our current plan that we've got, and there are some challenges we're discussing around the month 5 position, which will need to take additional mitigating actions during the last 6 months of the year to deliver against our original plan. Clearly, if there's additional request coming forward, we will assess that. But at this moment, our priority is to ensure that we can deliver what we've already planned, both in relation to the outturn position at year end. And clearly, we've already made a commitment to the public around the need for engagement and consultation about the longer term changes we need to put in place as a health board to address the key issues of sustainability, both from a workforce service and a financial perspective. So that work will still continue in the autumn.
Please, Chairman, to add.
Just to say, yeah, you're right, Robert, the financial situation is very challenging. We've picked that up under the financial agenda on that item. We continue to do everything we can to reduce our run rate. I think our focus is on delivering our deficit plan, as Hayley said. If there's any further ask, then we need to revisit the actions that we've previously taken in terms of looking at different scenarios. Those actions were things that the board discounted at that time, but we did complete that exercise previously, and we would be back into that territory and looking at those sort of issues.
Rob, would you like to come back?
I'm happy with that. Thank you, Chair.
Ron, please.
Thank you. Ronnie Alexander, independent member. I have a question around the annual report of the Ombudsman, which is something that I take very seriously. I do other work and have frequent contact with the Ombudsman. And if I go to page 8 of 9, in relation to the Ombudsman's report, I note that 67% of recommendations were complied with on time, which by extension means that 33% were not. So I wondered if it's possible to have some feedback on that particular dynamic. And the other thing that I will say is, I raised the fact a year ago, when this report last came to board, that the Ombudsman had offered to engage in training of people who were engaged in complaints handling. So I'd be interested to know if that offer of training was taken up, and if not, why not? And would that have had a bearing on the percentage of recommendations complied with in a timely manner? Thank you.
Thank you, Robert. Before we ask an executive colleague to respond, just to explain as well that this report will go for a more detailed conversation to our Patient Experience Quality and Safety Committee that Kirsty chairs, and so there will be that opportunity to consider these things, as I say, in more detail. However, Hayley, would you like?
Yeah, happy to come in, but I appreciate, I think you'll need further assurance to the PECS committee on the detail. On the first point, I think the deep dive around the proportion of 10 delivered versus 12 failing to be delivered in 23-24, you can see that our percentage of recommendations complied with on time is in the pack, but it's not as high as we would like it to be. So clearly the key issues, if you look earlier on the themes of some of the issues, some of these cases are quite complex, and therefore there are particular issues in terms of closure that I know that the team are working through. But I would suggest that you get a deep dive report from Claire Roche coming through to the PECS committee, and I'll pick that up with our Director of Nursing at the next meeting. With regard to the training, I know for a fact that the quality and safety team do have an ongoing training on complaints and have done substantial work to improve both the quality and the support across the organisation around complaints. The specific point about the input of the Ombudsman to that training body, I will need to check, but I do know there's a comprehensive training available to all of our staff, but I'd need to double check if they were helping us with the content or actually directly helping us with delivery. I'll check that to make sure it comes to PECS.
Thank you.
Thank you. Of course, Claire is not able to be with us today. Jane's with us. I wonder if you had anything you wanted to add, Jane?
No, nothing to add, but just to take the points back to Claire and back to PECS then.
Kirsty, please.
Yes, Kirsty Williams, Vice Chair of the Board. Just to give assurance, as the Chair has said, at the next PECS meeting, we will be picking up this issue on the agenda and have an opportunity to deep dive. think, notwithstanding the points that Ronnie has made, actually we've made really, really good progress in the last 2 years in the efficiency of our complaints handling. It's really good to see actually a relatively low level of complaints. And then what that does mean is that sometimes those complaints are more complicated because we're actually stepping in earlier. So the things that actually progress to the complaints procedure are more complicated. And because of our patient flows, it's also more complicated because we're often dealing with multiple organisations that will have been involved in a patient's care rather than directly in our own services. And sometimes then, because we're dealing with no numbers, it only takes 1 or 2 to make the percentage look disproportionately large. But just to reassure everybody that this is something that the PACS Committee takes a great amount of interest in at all of its meetings in terms of ensuring our complaints handling system is as good as it needs to be. We know that in the past there have been issues, but we are on a trajectory of a continuous improvement performance.
Ronnie, you content?
Yes, thank you.
Yeah, and you know, Kirsty, perhaps we could just make sure that Ronnie's questions are part of the discussion when it comes. Yes, okay. Thank you. If there's nothing else on my report, we'll go to the Vice Chair's report. Any additional comments, Kirsty?
No, thank you, Chair. I'll take it as read.
Does anyone have any comments or questions in relation to the Vice Chair's report? Thank you. And so we go to the Chief Executive's report. Hayley?
Yeah, thank you. Just to highlight a couple of points and to echo thanks to Steve for his contribution to the board, and also to welcome 2 new executive colleagues which will be starting over the next 2 weeks. Elaine Norton, who will be our Director of Primary Community and Mental Health, and also Nicola Johnson, our Director of Planning and Commissioning and Performance. Just wanted to draw out a couple of points, if that's okay. So clearly today we're not considering, we've got a special meeting organised for the 10th of October to discuss the engagement that has just recently closed on the 8th of September regarding temporary changes to services in Powys. I just wanted the board to be aware that we've had a really good level of response from the public regarding this, and there's rapid work being undertaken to fully analyse and present that information ready for our board meeting on the 10th of October. And clearly that will be of interest to the public and a really important meeting for us to consider the feedback that we've received from our communities with regard to those changes. So really good to see the level of response, but clearly a lot of rapid work needed now to be able to bring that back to the meeting on the 10th of October. Really also wanted to highlight the issues around the emergency medical retrieval and transfer service, the Wales Air Ambulance position. As you're aware, as a board, we considered this, and the Joint Commissioning Committee, which is the national committee to oversee this service, agreed the original recommendations, but there was one element, recommendation 4, which was around establishing a bespoke road-based enhanced critical care response for rural and remote areas, that there would be further work undertaken in a task and finish coming back to us for consideration in the Joint Commissioning Committee, which I represent this board at, in October. Just wanted to reassure board members that both Kate Wright as Medical Director and Stephen Powell as our Director of Planning, Performance and Commissioning are involved in that task and finish, and we will share the details after the meeting in October around the detail of that recommendation 4 and the service specification discussion. And there will be a period of engagement that will follow that meeting in October, which we will liaise with other parts of Wales on. And also, again, just to remind board members that we have had now the latest position around the challenge to the decision taken in the Joint Commissioning Committee, a legal challenge we last reported the letter before action that we had received on the 5th of July, but clearly now that that has been considered, we now are waiting for the next steps legally from the court, because there are clearly a judicial review has been brought. So I just wanted to make sure that those two key points were particularly drawn out to the board's attention. And then just again, had to mention the staff recognition. It's such a pleasure to be involved in that. Our teams are working so hard, and there's lots of progress that our teams and individual members of staff are making. So really encourage you, if you can, to join those sessions that we plan on a regular basis. Thanks.
Thank you, Hayley. Just before I invite comments and questions, just to go back to the EMERS situation, Hayley, I wonder if you might just like to offer a comment as to what we can expect as a board in terms of any future involvement in the recommendation for development. Will it come back to us for information, for consultation? You know, just to get a sense of what our role, if any, will be.
It's a really important point. So in the October meeting, we're expecting to receive the outcome staff and finish group and details of the service specification for the new service, which will then be the basis of engagement. And I would expect, after I receive that information, we will be bringing back to the board the details of recommendation for, because it was a key part of our discussion that we wanted that detail when we originally considered this position, for assurance and for information and for your views. That will come back. I'm not sure of the date yet, Carl, because I think that one of the key issues is checking the engagement period and making sure that we can get it back for assurance to the board as quickly as possible. But clearly the final decision will be coming back to the Joint Commission Committee after the period of engagement ends. So we will make sure that that comes back to the board for assurance.
That's helpful, thank you. Would anyone like to make a comment or contribute in relation to the Chief Executive report? Robert, please. Ronnie, sorry. Ronnie, please.
Thank you. One comment, Hayley, and one question. Thank you very much for this helpful report, first of all. Just to say, very pleased to see the reference to Sign Live and the fact that that's working effectively. I think it's so important that that BSL is seen to work effectively. But my question is, does this have the capability to be rolled out in respect of other languages as well, or is that not something that's built into the system?
Yeah, I have to check. Have the colleagues know the answer to that question?
I don't believe so, Ronnie, but we will absolutely double check. I believe it's specifically driven for the purpose of Welsh language.
Okay, thank you.
Anything else for Hayley in relation to her report? No? Okay, well, thank you very much, Hayley. We come now to item 1.7 and the reports from our committees. And as I always say at these meetings, the committees are really important to us. It's where the detailed scrutiny happens, and therefore they are very key sources of assurance to us as a board. And the chairs of those committees are therefore key custodians of that source of assurance. So we will work through the committees one by one and invite the respective chairs to offer an oral presentation or an oral introduction of the written reports. And so we go firstly to Hayley, the chair of the executive committee.
Thank you. So we've had 6 meetings of the executive committee since we last met, and you can see the breadth of issues that we cover within our meetings. Many of these items will feed into the relevant committees, but I felt it was important to draw out a couple of key points. The first one is my thanks to Claire Madsen and to Jason Crowler, Assistant Director for facilities for, in particular, the successful implementation of the body stores and decommissioning of the body stores across our sites. It has gone smoothly, and in particular really pleased with the way in which we've worked in partnership across the system, and particularly with our colleagues, funeral directors, etc., to make sure that the change has successfully been implemented without any particular issues. So thanks to the team for your work on that. The second issue is the continuous monitoring and discussions that we have around mental health escalation in the Executive Committee, and I know that that feeds into the Patient Experience, Equality and Safety Committee, but I hope you can see the frequency by which we have those ongoing updates, and the fact that we have been able to note really good progress with addressing the issues within that improvement plan. I think two other issues I wanted to mention, and I'll ask Claire to perhaps just mention, come in on one point, is that international nurse recruitment is really important for us as part of our workforce strategy to deliver sustainable services in Paris. And you'll note that in particular for us, finding accommodation has been a real issue for people coming to live within Paris. I'm referencing it because I know we've been working very carefully and in partnership in how we can take a more strategic approach to this, but we've had to take some shorter term decisions because we simply haven't been able to find accommodation in some parts of Paris to accommodate our international nurses. And also to highlight, and again, this is an area that was discussed in Delivery and Performance Committee, the work that we have undertaken around neurodevelopmental services. It has been an ongoing performance issue within our integrated performance report about the length of time children and young people in particular are waiting for assessment and intervention in neurodevelopmental services. And I just wanted to note that Delivery and Performance Committee did discuss that at their last meeting, but also that there are three elements to that work. We've completed the diagnostic on the position of the moment, developing that short-term improvement plan, but also needing to make sure that we look again at the model to be more sustainable for the future. And then I just wondered, Claire, whether we have used the acronym, but the Radiology Informatics System Procurement RISP is a really important national programme which we've been discussing as an executive over the last few months, but we just wanted to mention a few words about that.
Yeah, so this is a national programme across Wales to replace the information technology system that reports all of our radiological tests, and this is being rolled out across the whole of Wales at the moment. It's a really exciting project because it also brings capital investment, which enables us to replace our radiological equipment and update it, which means the quality of our testing will be much better, and it's actually much quicker, so it will give us increased capacity to do more testing within Paris. So that's very exciting. There has been a little bit of a delay with the IT part of this programme, but we think we're back on track with that now. However, the replacement of our equipment is on track. That will involve a little bit of disruption across Paris as we replace each of our X-ray machines in a phased manner, but it should be fairly efficient and quick, and it will be of a huge benefit to the population to go forward as we will be able to offer much better quality testing within our health boards. So just an assurance really that the programme is on track.
Great, thanks, Claire. That's all I wanted to highlight. Thanks, Carl.
Thank you. So, colleagues, anyone want to contribute? Please, Jo.
Thank you, good David. Jennifer Owen Adams, independent member. Would just love. It's really exciting to hear about that piece of work, Claire. When's the expected finish time? When do we think all that new equipment would be in place?
Well, we have to spend our capital money by March, so
Okay.
it's going to be quick to get the kit in.
Yeah.
So we've procured the first set of equipment now, and that's being planned to be put in. We've obviously got capital work around the rooms to make sure that fits for purpose and everything. So that will be very quick. The IT part of it might be a little bit later because that's an all Wales project, so we have to go in line with the timing for that. But it's very quick.
Good. Okay. So so our Paris citizens will be able to notice the difference, and should they need sort of imaging, diagnostics, etc., they will see a difference post-March, before March, because of the phased approach?
By the end of March, we will have the new kit in. The difference that will make is the quality of the images that we get will be better.
Yeah.
And it's much quicker process. It'll be quicker for the patients who come to have their testing, but that therefore gives us more capacity to fit more patients in. So I'm hoping that will reduce waiting times as well.
It's great news, John. Thank you.
Please, Ronnie.
Thank you. As Janice said, Claire, very exciting news. But I just wanted to check with you. A lot of imaging equipment I look at now is AI enhanced. Is there any AI enhancement that will be available for this equipment?
The kit we have has the potential to have AI enhancement. Whether we switch on or not will be dependent on the IT system, which is DHCW controlled at the moment. So I think there are projects looking at whether we can use AI to interpret some of our testing and things like that, but that will be a national project as to whether we switch it on, but we potentially have the capacity to do that in the future.
Well, if the capacity is there, that's a good thing.
Yeah.
Thank you.
Please, Nina.
Good morning, Nina Davis, Director of Social Services and Wellbeing, Paris County Council and Associate Member here today. Just talking about IT systems, I just thought I could ask, what are the plans for replacement of WCCIS? And I'm just wondering how that is, progressing across PTHB.
That's also a nationally driven programme, which is being procured by DHCW at the moment, Digital Healthcare Wales, and we are still in the procurement stage of that at the moment, so there are no further updates at the moment.
Okay, thank you.
Thank you. I can't see that anyone else wants to comment on the report from the Executive Committee, so thank you, Hayley. And we turn our attention now to the work of the Delivery and Performance Committee, our DMP Committee, and to its chair, Ronnie Alexander.
Thank you. I have tabled a 4-page report on the work of the committee at its last meeting, which was on the 29th of August. I will extemporise around this slightly and just say that, as always, we begin with a fairly deep look at finance position because of the importance of that in relation to the current position at the Health Board. And then I will move on to say that we spent a great deal of time and effort and energy looking at the neurodiversity children performance and planning update. And Hayley has already referenced that. We did have a look at that in detail, and I think we are assured that the process now has a logical and structured way forward. So we took assurance around all of that as an issue. And at that point, I will pause. Thank you.
Thank you, Ronnie. Any contributions, comments, questions in relation to the DMP report?
I have one, if I may, which is, Ronnie, I'd be grateful for your assessment of the volume of work that the DMP committee have to do, and wonder, maybe having this as a, ask you to comment as well. Are we satisfied that the capacity to be able to deal with all of the very significant number of agenda items that the Delivery and Performance Committee has to do, that, I just want to make sure nothing's falling through. I'm sure it's not, but I really appreciate the very vast volume agenda that you have to deal with, and conscious that we want to be able to support that as much as possible. And are you comfortable with that, Ronnie, I suppose, as chair?
Okay, thank you. And I'm grateful for the question, actually. From my perspective, what I will say is that the committee is heavily loaded. And I think, we are getting through agendas in an effective way, I hope. But I think we will need to look at some point at some structural reallocation of responsibilities. And I think it would be sensible so to do. Bearing in mind that I think we probably need to look in more depth at primary care issues.
Thank you.
Helen?
Yeah, thanks, Jen. Ronnie, I agree with you entirely. I think, you know, we monitor each agenda very carefully. We plan it and try to be very realistic about the allocation of time and all of those things. And Ronnie does a super job of getting us through the agenda as well. We're just now starting to see a little bit of shift. So, for example, information governance, we've moved into audit committee, as the board agreed earlier in the year. And we have, it's a very active flag when we do the terms of reference review this year, that we will absolutely need to consider whether we move anything else. If we need to consider anything earlier, of course we can. But yeah, under very active review.
That's great to hear that we've got that agility within, you know, within the year to be able to sort of compensate or react should we need to. So thank you. That's very reassuring. Thank you.
Thank you. So no one else wants to come in, then we turn to the work of our Patient Experience Quality and Safety Committee, PECS, and to Kirsty as chair.
Thank you, Chair. During this period, the PACS Committee met twice on the 30th of July and the 3rd of September. Before turning to the actions that have been previously brought to the attention of the board, I just want to say how pleased the committee were to receive the report from the Care Inspectorate Wales with regards to Cottage View in Knighton. It was obviously our work in Knighton is a slightly, is an extension of what is a quite unique model for Wales, and the additional bed resources that have gone in to Cottage View has been a really, really important addition to the infrastructure that we can offer people in East Radnorshire. And it was really pleased to see the quality of the offer in East Radnorshire being recognised by Care Inspectorate Wales in the way that they did in that report. So congratulations to all of our staff that are working so hard in Knighton, and indeed to the team that helped us deliver that change. Jason, David, they worked really, really hard to get us to that point. With regards to actions that have been previously raised with the board, in new things, we continue to focus very heavily on our delivery against our infection prevention and control report. That was scrutinised again in these meetings, and we were very pleased to note the adherence to that action plan, with all items being delivered to time at the moment, and we're moving into the next stage of the delivery of that programme. Obviously, with regards to the issue of escalation of our mental health services, again, the committee took a great deal of time to review progress against the improvement plan that we have for our mental health services, and took assurance that the systems are indeed improving. Many of the actions have been completed. We're not at the end of the time scale for that particular plan, so we're not in a position to receive a recommendation from exec colleagues to de-escalate. But that time scale, again, actions are being adhered to, and we look forward to receiving a further update. Previously, the board has had their attention brought to issues of staffing at Tower Ward in Estrygynlais. There has been some improvement in recruiting to Tower Ward in Estrygynlais, and the recommendation is that there's no further need to bring that to the attention of the board. And indeed, Helen and I and Elaine were at Tower Ward in Estrygynlais yesterday, talking to the staff, and it was really, really great to have the opportunity to spend a little bit of time with them. The committee continues to have concerns around our ability to have a patient experience capture programme as good as we would particularly like. That's not for want of trying. There has been heavy investment by the board in Civica and some equipment to capture patient stories, but we continue to have real challenges in the capacity of the team to be able to fully address patient experience and to capture that in the comprehensive and structured and strategic way that we would like. There is a paper that is due to come to the next committee, and we will have a further opportunity in November to explore this area in more detail. That concludes my report.
Thank you very much, Kirsty. If I may, just before It's very much that you and I also had an opportunity yesterday morning to spend some time in conversation with mental health colleagues on Glyndre ward here, and again to hear firsthand about the improvements that are being made in the services and so on. And also, I think it's fair to say the level of enthusiasm and morale, good morale amongst the staff that we met, and so that was really a really good thing to do. And Hayley, I don't know whether I think the point that that Kirsty raises about the ongoing capacity issues in relation to Civica, and also the need to really systematise the capturing, analysing, and using of patient voice. I don't know whether.
Yeah, I would love to comment if that's okay, because I think that I know Claire Roach can't be here today, but I've had a discussion with her last week about this issue, this very issue, because a couple of things really. Our performance as well of use of Civica is not where it needs to be in terms of the volume and rollout of Civica, but it's a broader issue. On a national basis, currently, the national team are updating the people experience framework, which I saw an early draft of yesterday, and also people's experience survey work. So my conversation with Claire, there is definitely a capacity issue for us to address. But I think that there is substantial work that's being undertaken nationally, which we need to take account of, first of all, and understand that. And we now have the first draft of both those frameworks to look at, which is really helpful. We've had some discussion about some review of resource and capacity in order to redirect on the issue of patient experience, patient voice. But that very point about how do we make it systematic, how do we triangulate, and how do we work across all of the system? And I'm thinking about primary care through to specialised services, and also how that we can strengthen this in our commissioning assurance space as well. Up here is for development. I think there's more to do, but I hope that when it comes to PEP, to be able to see a framework of what we'll be trying to achieve, and also we'll be bringing to executive committee probably in the next 2-3 weeks some discussion about how the profiling of some capacity to redirect towards this will be addressed. So I think it's such an important area. I also wanted to reference, obviously, the Lord Darcy report about NHS England came out last week, and we commission cross-border into England as well. So it's not just about how do we capture the experience as a provider, but how we're actually putting it into our commissioning assurance arrangements. And I know that this is an area which is very much tied to the annual report that we'll hear around the duty of quality as well later. So more to do, understand why it's being brought to the attention of the board today. But I think hopefully after the PECS meeting, the next meeting, we'll be able to give some assurance around the approach we'll take to address and build strength of this work.
Thank you. This is just a personal perspective because I'm not a member of PECS, but what I would just like to offer is the comment that I think if there's I appreciate that there are staffing challenges, of course I do, but I think if there is an over-reliance on QR codes for patients to provide feedback, the first thing is that the QR code doesn't always work. I tried it yesterday, it didn't work. Two, there are a percentage of people who don't have smartphones. Increasingly, that's the older aspect, the older dynamic of the population. And for a percentage of people who have smartphones, they can't cope with QR codes. So I think, we have to accept that in that system, we do lose people along the way. And we may need to look at what are the means by which we capture feedback from those patients. So I just offer that as what I hope is a helpful observation.
Thank you, Ronnie. Would anyone else like to contribute to this, to the response to this committee report? No? So thank you, Kirsty, and to your committee colleagues. We go to the Planning, Partnership and Public Health Committee, our PPPH committee, and its chair, Robert. Thank you, Robert.
Thank you, Chair. Yes, the 13th of August. And I'd like just to highlight three items really. The first is the strategic change report. And the way that this is collated and presented has improved thanks to Stephen and colleagues. And it represents the easiest way for members of the public and indeed independent members on the board to see how this health board is and could be affected by changes elsewhere, other health trusts and boards, particularly since most of the proposals historically are eventually implemented. There's no doubt that the pace of change has accelerated due to the financial pressures, but I do commend this report to everyone, and it is provided quarterly. Second, transformation better together. We've had in the last couple of years lots of plans and ideas coming forward under this banner, and the committee looks forward to measuring the impact of transformation, both financially and in terms of improved service, particularly now that changes are being led within the new Directorate of Improvement. That is our expectation. And lastly, the deep dive in diabetes, and the public health team, ably led by our director and also consultant, presented us with scenarios for both the increased numbers of patients with diabetes 2 and the associated costs. And the scenarios showed roughly that there will be increases in patient numbers by 2035 of about 10%. And their treatment will require real-term increases in expenditure. It's plausible that the calculations underestimate the numbers, but we've gone as far as we can with this work reasonably, and the project is therefore deemed complete. Thank you, Chair.
Thank you. Colleagues, any contributions in relation to this committee report?
Chair, I noted in this report the work around tobacco control. It just prompted me to ask about what, if anything, are we doing with respect to vaping, which seems to be a kind of ticking time bomb, really. And I just reflected on hearing reports of a study of vapes taken from school children showing large amounts of spice, a highly addictive drug. I just wonder where health boards generally are in terms of what seems to be a public health concern, and what kind of things are going on nationally or we should be giving attention to.
I think we asked a question on this actually, vaping, and also about drugs as well. So Nez, she's got there. She's probably better to give us the response that you gave in the meeting as well. Thank you.
Yeah, thank you. Nez Bowley, Director of Public Health. So thank you, for raising vaping, particularly over the last year. We've seen quite a rise in the last 12 to 18 months in vaping in young people in particular. Sort of thing. I sort of lead as one of the Directors of Public Health leads for tobacco across Wales. We did have Public Health Wales led task groups over the last summer to look at the evidence base, looking at driving element of that, and based on information as part of that, particularly on young people, single use vapes seem to be driving some of that sort of change in terms of behaviour. So locally, what we did was last summer set the task and finish group across the partnerships, local authority, voluntary sector, and really, and on the back of that, developed resources for our education system in terms of toolkit, as well as a involving young people in co-producing vaping campaign element, which went live in April. And then in addition to that, we also do, and actually there's one in the next 2 weeks, online sessions for teachers around the toolkits for schools.
Thank you.
Just before we move on, Robert, the deep dive into diabetes, I think, is really both fascinating, very useful, isn't it? Really good to hear that. I suppose the question it begs is the so what question, will that be used and how will it be used in our future planning? And if that has proved so useful, are there any other areas of focus that the PPPH committee will look at in order to inform our future planning?
The reason that I was keen that we did this work was that it makes real, if you like, the extra demands that will come in time. And one of the other possible projects was dementia, but for various reasons, availability of data and so on, and equally good, we chose diabetes. So in principle, we could extend it, and it wouldn't be unreasonable to suppose that there would be similar demands elsewhere. As far as the use of this is concerned, there will be, of course, extra demands of staffing as well. So it will allow us to think, because 2035 is not that far away. So it will input into that as well. But I think the most important reason is that it rather than talking about a sort of blanket increase, we think there will be greater demands across the piece. It crystallizes with this. And I think that's, when it comes to specific planning, it is nothing like having concrete information in as far as we get it. So I don't know if, Mez, you agree, but this could be, we have to be careful that we don't overload the team. It's very demanding kind of work, because it has to be, if it's going to be valuable, it has to be comprehensive and as good as we can get. But I would like us to do more of this, but we have to be conscious that there's a lot of current daytime work, if you like, that also got to be.
I suppose on a general sense, I suppose my question really is, rather than this just be an end in itself,
yes,
what's the end to which it is a means? But Jen, and then.
Well, I am sure Mez, would want to come in and having heard and being part of that committee, of Robert's committee, I was really delighted to get that report. And for me, I think what really struck out to me were the opportunities for early intervention and prevention. So we know what the trajectory looks like, and we know what needs to be done in order to try and minimise that trajectory as best as possible. So for me, the so what is, what can we do now to mitigate what the future could look like in relation to diabetes? Do you think that's fair, Mez?
Yes, yeah. Can I
Please do, yeah.
have to say, thank you. Will Ken did an excellent piece of work in terms of deep dive, which does take, a lot of time. But Steve and I have had a conversation, and Steve will come in a minute. It does look across the pathway. We know what the trajectories are, and there needs to be action across that pathway element. So we did in the paper to say, in terms of forward planning, we'd be looking at working closely with planning in terms of the IMTP, but also how we socialise it as well. New transformations. Steve.
Yeah, thank you. And good morning, everyone. Steve Powell, Director of Planning Performance Commissioning. Just to build on what Mez said, and certainly from a data perspective, there's an enormous amount of data within the NHS, be it coming out of Public Health Wales or other data that we receive ourselves. I think the key thing going forward is getting our planning more sophisticated. So looking at the number of patients that are likely to be living with multiple comorbidities. If we can build that into our planning and our service redesign, we'll have a better chance of trying to meet some of that need going forward, because the need is known both now and in the predicted future. It's how we build that in. It's going to be really important.
Thank you very much. So Kirsty wants to come in, so does Kate, and then we'll go finally to Hayley before we move on to the final committee report. Thank you, Kirsty.
I think, to speak to Steve's point, I think the report is a really, really valuable piece of work to inform planning and workforce development, as well as then the agenda of trying to flatten the curve to try and change that trajectory. And therefore, there's the evidence base then to support, for instance, the work the Mez's team and Claire's team do on weight management, early intervention, the new breastfeeding initiative in conjunction with the council. So it helps provide the evidence base for investment into those services, which otherwise are services that quite often are not going to get the attention that they need and deserve. So I think it's really useful for that. But it does strike me in two of the areas that I've been looking at recently, that dearth of data and the fact that we haven't done some of that planning has potentially hampered us. So that's true with the neurodevelopmental stuff, not really understanding where our trajectories are going, what we need to plan for. That work is now being done in conjunction with Mez's team to really get underneath that. And yesterday, you know, the conversations we had with the mental health colleagues in the Lindra ward, we know that demand is changing, and we need to get ahead of that, and we need to be sighted on what our services will need to deliver, not just today, but actually where that demographic is taking us, so that we can design those services appropriately. And that's what colleagues in mental health were saying to us yesterday. And I think this piece of work could be a template for getting ahead on some of those other, you know, wicked issues that we're going to have to deal with as a health board, but doing so on the basis of really, really sound and methodical research. So I think that's the value I see in investing in that piece of work. But as Robert said, it's intensive, and I think is really, really important.
Kate.
Yeah, thank you. Wow, so much to say. So absolutely that it really emphasises the importance of the left shift, trying to keep an eye on prevention whilst we're trying to firefight at the same time. This is incredibly important because we know my ambition would be to never to get to that trajectory.
Yeah.
So that's probably should be our number one. I think it's really useful piece of work. It's useful to triangulate it with others. A lot of work going on nationally on diabetes. The National Value and Sustainability Board has obviously got an eye on it as well, rightly so. And so there's now a fantastic dashboard, the DEVA dashboard, which is going to give us the data we need to drive to change. So one of the things we struggle with is data in terms of really understanding where we are and changing behaviours, but that dashboard is fantastic. So we're discussing how we're going to bring that into the health board, how we're going to use it, and triangulating this with that piece of work, you can really see how we could start to make a tangible difference. So a lot to do, but I think in terms of other work, I think, you know, given our capacity, then there is something about prioritisation. Where are we going to have the biggest impact? And this is definitely one of the places we have the biggest impact. And you're absolutely right, Steve, it fits in with the things like obesity and hypertension. So there are a few things that fit together, and if we're really clever, we can try and marry a few things together and achieve the same thing through one stream of work rather than multiple. So I think it's really exciting. You can really see how we can progress this now.
Okay. We probably need to be quite brief now, but Claire wants to come in. I want to come to Hayley finally. But Claire, briefly, please.
Yeah, just quickly, as clinical directors, we're also doing some national work to influence the higher education programmes that are training our future staff, because it's really important that the new staff coming through have a real public health focus and a prevention focus, and the skill set to work and make I think the phrase we use is make every contact count, so that they're really working with people to maximise their prevention skills. So I think just to note that as well.
Hayley.
Yeah, really helpful comments from everybody. I think a couple of things. Kate's mentioned it really, there are a number of national work streams at the moment, and clearly it's that capacity for that public health analysis through the Public Health Observatory, etc., and the development of some of that. We'll be able to use that more locally. But I think I'm going back to our strategy that we set, I know in 2017, but we did the initial assessment there based on population wellbeing assessment around where our big four priorities would be. So Kate's really drawn the point, we can't be scattergun, we've got to go where the evidence-based and where the key issues for our population are. So it's how we have that conversation through the PPH committee to make sure that we're taking an evidence-based approach to this. I think the points that people have raised about the importance of early help, focus on wellbeing and prevention, that's been our strategy since 2017. And that resource mapping conversation is a particular challenge, I think, for us that we have to address explicitly in the revised IMTP discussions, annual planning, but the longer term plan that we put in place as a health board. But clearly it's the right thing to do, because we've got to find a way to try and shape future demand and change future demand. The diabetes work was really interesting from my point of view. There is a number of priorities that are being set nationally for us to look at, and the first test is making sure that that does chime with what we need to do locally as well. So I think this is an ongoing discussion for the PPH committee about where do we go next and how do we take it forward.
Thank you, Hayley. So, sorry, Nina, okay?
Sorry, thank you, Chair. I think I'm a bit far away from you.
Oh, I'm sorry, I
I'll
was.
move bigger, it's fine.
Apologies, yeah.
Yeah, I note the committee received a report on the newly established Directorate of Improvement and Transformation, which I think is really positive, exciting. And I'm pleased to note, you know, the sustainable powers and the fact that the transformation alongside the council is kind of referenced. But I was just wondering, was there any discussion about working alongside other partners as part of that transformation? Because I think it's really important that, you know, we're looking at across the sector, health and care, and of course, third sector and other partners are really important to that. So I was just wondering if there was any discussion about, you know, working with other partners in terms of the transformation journey.
I think where we are really is identifying who those partners are, and we want to get that right. So we're not backtracking, but it is on our radar. And I think it'll be particularly important as we look for, if you like, the concrete proposals and the value coming out of the work. So it is part of our ongoing work, and it's very much in this sort of next stage. But yeah, so thank you for that.
Thank you. Robert, there's a lot of appreciation and appetite for the work that the committee is doing. We look forward then, as colleagues have said, to see how your committee focuses its attention on in that evidence base, you know, within capacity constraints and so on in the future. But thank you for that. Finally, under this agenda item, the Charitable Funds Committee that I chair, the only additional comment I would add is a thank you to our interim charity manager, Martin O'Brien. And I think the report demonstrates that Martin is building very effectively on AIDS work and helping the committee to really focus its attention on its strategic responsibilities and improving the way in which the committee receives information and monitors the work of the charity and so on. But so that's it seems to me a very good trajectory that we're on. But apart from that, I don't have any other additional comments. Happy to receive. Yes, please, Steve.
Hi, Steve Elliott, independent member. I've had the opportunity over the last 2 or 3 months to get around the various hospitals in the state with Nick as a colleague, and what struck me, I think, is some areas, some hospitals which have had quite significant investment from League of Friends to enhance the external part of the estate, and other hospitals where that hasn't been so forthcoming, and you mentioned in your report around the winding down of the Newtown League of Friends. Newtown, I think, was one particular area where the garden needed some investment. I just wonder how we ensure equity, I think, across our whole estate in terms of enhancing the environment, because obviously it has probably quite a significant impact in terms of recruitment and retention of staff, for them to be feeling they're working in a good environment. Obviously has a big impact for patients as well.
Yeah. Thank you, Steve. I mean, perhaps the first thing I might just say is that we now have our new Leagues of Friends forum, which enables greater cooperation and coordination with the Leagues of Friends. Of course, Leagues of Friends do vary, and they vary in terms of their strength. They vary in terms of the amounts of capital and they have available and so on. As you noted, Steve, very sadly, the League of Friends in Newtown has decided to dissolve the charity there, but we are actively supporting them to wind up in a healthy way, and also in discussion about how we continue to support the community in and around Newtown through the health charity to raise funds and support the hospital there. But in terms of the ensuring equity of provision, as it were, who would like to respond to that? Please, Helen.
Sorry, Hayley, did you want to comment?
You have to go first, I can come after.
Yeah, thanks, Steve. Thanks for the question. So we've obviously got Leagues of Friends support. We've also then got the money that comes to within the charity itself. And one of the things that we did two things we did at the last meeting really. One, we looked at a different way of reflecting the performance figures and the allocation, but the granting of funding, if you like, so we can have a better picture as a committee of what money is going where, both historically and moving forward. So that will help address some of those points that you've raised. Martin and Shania have also just been re-looking at the grants that we have available and the way in which we promote those and how we engage with staff more locally. So there is some work in train that I think will help us with that. But you're right, there is a difference in where money's been received historically. And of course, some of the money we have is ring fenced to certain hospitals through certain donations. Some of it is more general. So I think we've identified that, and there's work to help with that into the future. But Hayley has a few more times.
No, that's great.
See, okay. Thank you. So that concludes our discussion on the various committee reports. We have later on our agenda the items under the consent agenda, which are, just to explain, the consent agenda are items that we deem to be not needing discussion, but nonetheless do need approval or decisions, but that we can deal with them en bloc because we think that they don't necessarily need discussion today. Does anyone want to, if you like, raise something from the consent agenda and place it as a substantive item on the agenda? No. Okay, thank you. So we go to two annual reports now, and because of the way we operate, a lot of our annual reports now actually are dealt with within the consent agenda. However, the two that are substantive items for us today are substantive items because they are very key and very important reports for us. The first, the duty of quality reports, and Jane, I think, is going to speak to this. Thank you, Jane.
Hi, Jane Rees, Assistant Director of Nursing for Safeguarding. So I'm pleased to present the first annual duty and quality report for 23-24. The report provides an overview of the health board's development and progression within the quality sphere and alignment of the quality management system, which will further mature during 2024-25. I'll take the report and covering papers as read and ask that you note the report received a thorough discussion at PECS on the 5th of September. Thank you.
Thank you, Jane. Kirsty, in terms of, I mean, you've already given your PECS report. Do you have any particular comments on this report per se? It doesn't need to be.
Just to say that the committee received the report and took assurance that in what is the first year of implementing these new statutory requirements upon us, there's been a huge amount of work done, and we're pleased to note the impact that the legislation is having. I think it's fair to say that at the beginning, perhaps some members of staff were really, really concerned this was an additional burden that would be placed upon them. But actually, the way in which management have been supporting staff with duty of quality and duty of candour has been to remind everybody this isn't additional. This is actually the core of what we do. And I think, and certainly in the time that I've been here on the board, quality is now at the forefront of every discussion that we have. It's not just seen as the responsibility of the nursing team, it's actually everybody's business. And we were very pleased to see the report and how we as an organisation are maturing. I think what was also interesting to note is that efficient use of our resources is a quality standard. Sometimes when we're discussing issues around finance, it can be seen, and sometimes the accusation is raised that this is all about money, that's what you care about. But actually, it was a useful reminder to all of us that actually efficient use of our resources, including our financial resource, is actually a quality standard. And that's why we do need to ensure that our financial resources are used efficiently if we're to meet our statutory duties around quality.
Really helpful, thank you, Kirsty. Would anyone like to, please, Nick?
Excuse me, Richard Nassy, independent member. I enjoyed reading the report. It was, kind of informative. I like the way that case studies have been brought out to kind of bring it to life. Describes, quite a significant amount of progress made in a short time. I appreciate it's a first report and therefore it will evolve. But I think the question I was left with at the end was, who was the intended audience? So in parts, it was written in a kind of view, as if it was intended for a public audience. But in other parts, it was quite technical, describing systems and processes. So it's just an observation, really, I think, as the report evolves, but just some thought about who is this intended for, and maybe some kind of segmentation in the way that it's presented. So quite clearly, there is a kind of statutory duty here, so we have to present it in a technical fashion. But if we want to speak to the public, then maybe it just needs to be kind of lightened, and maybe different versions for different purposes. But it's kind of very comprehensive. It paints a very positive picture. But I was just left with that: who is this for, and could we present it differently going forward for different people?
Thank you, Hayden.
It's a really important point, Mick, and I think we have this dilemma with a number of reports that we do. I think we'll have to think about reflection about how do you bring a more everyday version, public version for some of these reports, more summarised, because the requirements are quite specific to cover a lot of detail. So there's an action for us there around which reports we would want to think about around that, because it is in part giving us assurance as a board of the progress that we're making against the duty of quality, but also that public lens is important. I guess the other 2 points I wanted to raise is that we have brought quite a few things in recently. So the integrated quality performance assurance framework has been a fairly recent development for us that supports our approach to managing our assessment and escalation of services, for example. So I think it'd be very interesting to see how we monitor that and bring that through for future reports. And I really am pleased that we've got a stronger arrangement and framework in place through that work. And the other issue is a cultural piece for us as a board, because board have the responsibility to lead the culture of the organisation. And there are a couple of specifics pulled out around speaking up safely, but we've just talked about patient experience, but staff experience and well-being is absolutely key to this work as well. So it's sometimes there will be different parts of the detail in other reports that the board will come and consider. And I think I'm particularly interested to see how do we bring this together under the duty of quality, recognising there are separate reports potentially dealing with large aspects coming through to various committees and to boards as well. So a learning one. Our first report, I'm really grateful to the team. It's a good report. It's a very great start, but I think there's a little bit of tidying up for us to do around how do we bring these elements together under the duty of quality.
Ronnie, please.
Thank you. I was said to Claire recently that when I sit down with the service, not here, but elsewhere, and I say to them, tell me about your quality management system, I'm actually met with a look of blank amazement. And so actually for me, and this chimes, I think, with some of the points that Mick has made interiorly, staff, they need to understand that it's a personal issue, it's real to them, and they're important in its delivery. So I just want to make that point without over-egging pudding. Thank you.
Thank you. Steve and then Robert.
Yeah, thanks again. It's a great report. I particularly like the infographic on page 11 with around patient experience, and we have touched on that earlier. So I'm just struck by some of the. I know it's a snapshot, but particularly sort of less than 40% felt they'd always had assistance when they needed it, which felt quite low, and even to say a third of our patients were saying that they hadn't understood what was happening to their care. So I suppose it's a similar point to Mick, really. I think what would be helpful, not necessarily to have an answer, but is to sort of describe in the report how we respond to those, to that feedback and particularly where that might be particularly low and what actions we're taking to address that.
Robert, and then we'll go to back to Mick.
Just to say that it's not always realised that within the definition of quality is timeliness. We've got a lot of information about the timeliness of our secondary commission services. And this is why I think it's important at our last meeting that we committed ourselves to work with FLICE to, for example, to understand what access and speed of access needs primary care as well.
Thank you. Mick?
Just to build on Hayley's suggestion that, kind of thinking about these things the way we going forward, how they're presented and how different audiences are reflected. There's an increasing number of these reports. When every board meeting we have a report about something. I just wonder whether there's a wider piece of work around the corporate style. So if you contrast this report with the next one, which is presented in a different way, which does speak to a staff public audience, it's kind of segmented and it's quite light in terms of the way it's presented. I just wonder whether there's a piece of work to be done. There's enough work to do, I understand, around the kind of house style, the corporate style, this kind of report, and some thinking about tone of voice. What do we want to say and how do we say it through these reports? So, it's a longer term issue, but I think it's increasingly becoming part of the landscape. And it's these are the outputs of the board's work, aren't they, in the public domain?
Really important point to health. Thank you, Mick. Helen, I'm sure we'll pick that up. Whether that's an issue for the chairs forum or whether it's the executive board, but a really important point. So we'll go to Steve. We'll ask Jane if you have any any final responses, Jane, and then we'll move to the next report. Thanks, Steve.
Yeah, thank you. So I was just going to mention that obviously we commission a lot of services out of county, and that quality lens features heavily in all of our interactions with those providers. So we tend to meet them, each commission provider on a monthly basis, and as well as finance activity, there's a clear agenda item around quality, their feedback, and then how their respective teams deal with very specific patient issues, as well as general comments around access and patient experience. So just to give you that assurance that is part of our ongoing dialogue.
Any final response, Jane? You don't need to, but just to give you an opportunity.
I need to thank you for the constructive comments, which I will take back into the team. Thank you.
Okay, thank you. So the recommendation is that we approve the annual quality report. I assume that we do. There seems to be a consensus in the room, but please indicate if you don't. So that's approved. So we turn our attention now to the safeguarding annual report and back to Jane.
Thank you. So I'm also delighted to present the annual safeguarding report. The report presents the key areas which have supported the Health Board meet its statutory responsibilities for safeguarding. Again, I'll take the report and the covering paper as read and ask that you note that the report received a thorough discussion at PECS on the 5th of September. Thank you.
So again, an opportunity for you, Kirsty, to add any comments?
Just to say, once again, we're really pleased with the outcome of the JICPA review, which is very welcome, and noted the action plan that has arisen out of the JICPA report and how that now is being progressed to ensure that those any recommendations are taken up. Thanks to the team. This is a really important, highly complex and specialised piece of work, providing safeguarding support for the organisation, and we're very grateful to the staff for the way in which they support the organisation.
Thank you, Kirsty. Does anyone want to come in relation to this? Please, John.
I just wanted to add, I am a member of PECS and obviously completely endorse what Kirsty was saying there. But what I was really impressed with when I first looked at this report at PECS, and indeed I asked a question about this at PECS, was the quality of the multi-agency partnership working, which goes on in this space. I mean, it's a very, very important piece of work. I hold a safeguarding lead on another board, and which is, I'll I'll leave that there. But so I am fairly familiar with this work. And I just wanted to congratulate the team on the work that they are doing in that multi-agency partnership working space, because it is complicated. There are a lot of agencies and stakeholders to work with, but it's incredibly important, isn't it, that those processes are robust and tight. So I was really reassured about that, and I just wanted to offer that positive feedback and thank and congratulate the team on that work. So thank you.
Thank you very much, Jen. So, well, thank you for that. So again, we're asked to approve the annual safeguarding report. I'll just pause if should anyone want to indicate that they don't approve. Therefore, no one is, so that's unanimously approved. Thank you. We now go to Helen, our Director of Corporate Governance, for her report. Thank you, Helen.
Yeah, thank you, Carl. So, and with slight apologies, normally the content of my report has some items for the board to approve, because in why it's in this section of the agenda today, that's slightly different. So I'm offering this report really for your information, for you to receive. There are just three, it's a short report, there are three aspects to it. So we continue to be very focused on our statutory obligation, but also moral obligation and commitment to make sure that the public is aware of when the board is meeting and how that works. And as board members, you'll be aware that we had 2 additional in-committee meetings in August. Those are listed in my report, and just again making sure that the public is aware that those have happened. And obviously an hour in committee later, as a board, you'll consider the fuller minutes of those meetings. I've also just summarised often, Carl, you refer to these in your chair's report as well, but just summarised the fact that the board continues to hold its monthly board development sessions, and just summarise the themes of those. And again, since we last met in public in July, we've held 2 board development sessions. And then finally, just a piece of information, the importance of hearing from and listening to the public continues to be a real focus for us. We haven't previously had any form of guidance or protocol around petitions, how we receive those, how we handle them, how we respond to them, and importantly, how you as a board are made aware of them. So just to confirm for everybody, we have now got that petitions protocol in place that is available to members of the public as well. So just wanted to make sure that the board is aware of that.
Thank you very much, Helen. So for information, but so no decisions, but does anyone want to respond or comment on the director's report? Okay.
Thank you. I just want to welcome the development that we've introduced, which is the chairs of each of the subcommittees to this board now meeting. And sort of join the dots, so to speak, between all of our relevant subcommittees. And I know that's been a work in progress, and that is now up and running. And because I'm now the new chair of the Workforce and Culture Committee, I look forward to being part of that. But I think that's a great development, and thank you, because it's something that I've been asking for, and it's all up and running and doing well. So thank you. Look forward to being part of that. Thank you.
Thanks, Jen. Hayley?
Yeah, thank you to the corporate governance team for your work on the petitions protocol. I think that clarity is welcomed and really useful for us. I know it referenced that it will be reported at least annually to the board, but clearly if it is relevant to decision making, that petition will be part of the response we'll be considering for any decision. So I just wanted to make that point, that clearly that will be something that will be brought through for relevant items as well.
Doesn't seem like there's anything else in terms of this report. So thank you, Helen. And we go to item 3.4 on our agenda, and proposed changes to the governance documents in relation to the Joint Commissioning Committee, the JCC, which of course Hayley referenced earlier when Hayley was talking about the EMERTS decisions. But Helen.
Yeah, thanks, Carl. So just to give you a brief introduction, so what you have quite a package of papers here. There's a brief cover report from me, and then we've attached the reports and papers that have come directly from the Joint Commissioning Committee. As you said, Carl Haley is our member, as our Chief Executive that sits on that committee. So Haley, you may want to come in a short while as well. So just a quick recap. The Joint Commissioning Committee, then the JCC, is a joint committee of the 7 health boards in Wales. Previously, we had separate committees for both specialised services and emergency ambulance services. That's been put together from the 1st of April. And back in March of this year, as a board, we agreed a different set of governance documents, including the standing orders, standing financial instructions and some other things. So we knew further work was then coming, which is now what's sort of arrived today. So this is the further, it's not a change to what you've approved previously. These are additional governance documents, essentially setting out a little bit more of the detail of how some of the subcommittees of the JCC will work, but also the memorandum of understanding, which is particularly important, I think, because that's between us as a health board and the JCC and the relationship and how that operates, but also for you as a board to have full sight of the hosting agreement that sits between the JCC and ComTAF, Morgana University Health Board as the host body. So the JCC itself have considered all of these documents when it met on the 17th of September. Hayley was in attendance and contributed to that meeting. It is a relatively complex governance arrangement, and there is ongoing work, including through these papers, to make sure that it is as clearly set out as possible what the JCC's relationship is and its own assurance committees, which is part of what you've got in this package, what the JCC's relationship with its host body is, ComTAF Morgana, and then importantly for us, what the relationship is with us as one of the other 7 health boards, because there are a number of areas that are retained to our board for decision and for recommendation, but there are a number of things that are delegated. So continuous work goes on with that. But hopefully what you'll see in these papers is the next stage of information, if you like, which I think is really important from an assurance perspective. All of these documents are reserved to our board for approval, as they are the other 6 health boards. So in the window of these September board meetings, all 7 health boards will be considering these documents. But Hayley, I don't know if you were obviously our representative at the meeting, that you'd like to add anything.
Yeah, no, not particularly. I guess the one point I would raise is that there's further work to be done on this. Is clearly previously we drew membership of some of the subcommittees from independent members across health boards in Wales. So I raised the point about the reporting lines back through to our PECS committee and through to board, and how we ensure that is as strong as it needs to be, both to our committee but also into our director arrangements as well. So there will be some further work around how we bring the partnership reporting through JCC, both to our board, but also the important role of understanding that we understand that our population and equality, safety or outcome concerns dealt with in the subcommittee. We've been lucky previously, Kirsty, you sat on that committee, but the membership is different now. So I think there will be some work for us to do about the reporting going forward as a result of these revised arrangements. But other than that, I think further to add.
Thank you. Would anyone like to contribute? So, okay, so we'll go to Steve, to Ronnie, and then to Jen, please.
Yeah, well, thanks, Hayley, because I think that was the point I was going to raise, concern about how, because ultimately as a board we retain responsibility for the quality of care commissioned on our behalf by JCC, as well as their performance and financial position. I think it's important that we do have a good solid process in place, that we as a board, and particularly us as independent members, can interact with the JCC arrangements and take assurance that they are operating effectively. So I look forward to that work when it's done. Thank you.
I think Ronnie, sorry.
Thank you. I just wanted to ask about the memorandum of agreement. Is that the same as a memorandum of understanding, or is it different? And if so, how is it different? And I just wanted to say that I have a personal reflection on MOUs, which is a very personal, which is constitutionally you need them. Of course you need them. But actually, if you ever get around to having to interpret them, you know, you've lost the battle for amicable resolution. So I was just interested to understand what a memorandum of agreement was.
I think memorandum of agreement is the term that's set out in effect, the regulations that set up the JCC. To be perfectly honest, Ronnie, from a legal perspective, I would need to go and do a bit of work to really unpick the difference. I'm not sure if they are very different. Yeah, you know, I need to go and take that action and have a look, to be honest. But I think, unless Hayley, you have anything to add, I think it's essentially a reflection of the language that's used in the setup of the regulation.
So I can't answer the specific difference, but what I can say is the model of a memorandum of agreement has been used and is used more broadly than in this context around the JCC as well. So in other hosting arrangements that are in place between national bodies being hosted by health boards, but we can check it, Ronnie.
I have no wish to involve others in additional work. It was just a question of my understanding. Thank you.
We go to Jen and then to Kirsty, and then we'll probably need to go to the recommendation.
Thank you, Chair. I think my question has been answered by Hayley and you, Steve, but I just want to make doubly sure. I found this really quite complicated and complex to understand. And really the question for me is, are we confident that these new arrangements will give us the traction, the influence, the voice of Powys that we need? I think that may be your point, Steve. I don't know. And I think, Hayley, you were saying that the reporting mechanisms back and our interaction and our traction within these new arrangements, we are satisfied that our voice and our needs will be understood and heard and acted upon, given that this is a national thing. But I just want to make sure that we are comfortable with that, and there are processes in place to ensure that we as a board are assured in that space as these new processes develop.
Okay, so sorry, can I just bring Kirsty in now?
I think it's really important that we have got that assurance. So, how would we know over the last year, 18 months, there's been real concerns in the Quality Committee around services for children at Cardiff and Vale. Everything from infection prevention and control through to the waiting times. So what we need to know is, how would we know as a board in Powys that those concerns exist, and more importantly, having identified those concerns, what actions are being taken by that service provider and now the JCC to address those concerns. And I would suggest that's the kind of the assurance that we would need, and the information flow. How would we know that, and how could we influence that? The previous regime has been quite interesting, because you sit on that committee alongside independent members who represent boards who are providing those services. So there's almost you could end up with a conflict of interest, because people may choose to defend their service because their organisation is providing that service. I'm not saying that happens. People have been really open to wanting to do best, but it's about that, having that information flow, so we know as a board what those issues are, what the concerns are, and what actions are being taken. That's what I suggest we would need to focus our attention on securing that arrangement.
Okay, lots in there. The first thing to say is just we've got to remember why the original review that has led to the establishment of the Joint Commissioning Committee. And it is this first transitional year bringing together the Emergency Ambulance Services Commissioning 111, Sexual Assault Referral Services, as well as the really key work around Welsh Health Specialised Services. The whole purpose around that was about collectively bringing together the importance of nationally required services, where we're pooling expertise and developing a more consistent approach across Wales. So in answer to your specific question, we are one of the 7 health boards, and we have an equal status on the board. But clearly, the decision making around the JCC is no longer based on consensus; it's based on majority in terms of decision making. So there will be circumstances potentially that we will have a view for the Powys population, but actually looking at it from a national population lens, what's best for Wales may be a little bit in conflict. So in the conflicts you've raised is around the difference between a provider and a commissioner, we will potentially have the conflict, or I will, as your representative on here, that I might have a view for the Powys population, but actually in the best interest of the Welsh population, it may be a different outcome. So I think we would have to say that this transition year is a settling in. It is complex, and I think there are some key questions that particularly the directors of corporate governance around the handling of conflict of interest, who are members, who are attendees, have been working through some really quite difficult issues. And I think this is the accumulation of the work for this first year, which we need to recognise might need to be reviewed as we progress. And clearly, I just mentioned at the start, the judicial review legal challenge around the EMIS decision, is testing the waters with the new arrangements that we've got. So to answer your question, how can we be assured? I think what we need to do is to ensure that that reporting line is absolutely crystal clear. And I think it does need to change and be strengthened because of the change of membership. And then the second is to ensure that we're giving this sufficient time. So you'll see a little bit later in our financial report, the particular financial challenge the JCC is currently covering, which is actually exposing us to risk as an organisation to probably circa £1 million. It's probably a bit more now. So there are some fundamental questions there. So I can't really answer your question yet, Jen.
No, I understand.
Can we be fully assured? What I can say is we've got equal status to other health boards and equal collective responsibility to make sure these arrangements work. Whether it improves, it would be fair to say also that there are new workforce arrangements being put into it's a new team, new senior appointments, and it will take some time for those arrangements to bed in. So the key issue for me is for the joint committee, and in the last meeting I was crystal clear about the financial issues are really focused on the top several issues, and for example the discussion around paediatrics and intensive care in Cardiff and Vale was discussed. So I think it's okay. Whether it will improve is a question for us to probably test at the end of the first year. But happy to bring
that's fine. That's fine. Thank you.
I know Steve wants to comment. Then I do want to close this item quite quickly. So Steve and Helen, brief.
Yeah, thank you. So we recognise that the Performance Commissioning team need to strengthen our internal reporting back into the organisation on all those activities of the JCC. So you will see in future iterations of our delivery and performance report that discrete focus, additional focus on those areas of commission services.
Thank you, Helen.
Thank you, Carl. Just to quickly say, one of the commitments within the governance arrangements is that the JCC chair and some members of the board come and visit and engage with each of the 7 health boards, and we're just in the process of arranging that for a board development session either in December or January. So there will be an opportunity to further explore some of this from a practical perspective as well, and I think that will be important.
Thank you very much. It's a truism, isn't it? Really important stuff. And as Hayley says, we are where we are within that journey. We will be receiving more updates and so on, and a work in progress. If things do need to flex and change in future, then we will have the voice, as it were, as Hayley has described. So we have a number of recommendations here that require our approval, and then there is something that we are simply asked to note. But I will go through them because they are very important. We are asked to approve the terms of reference for the JCC Quality, Safety and Outcomes Subcommittee, the terms of reference for the JCC Planning, Performance and Finance Subcommittee, the Memorandum of Agreement and the Hosting Agreement for the JCC, and the continuation of the transitional reporting arrangements for the IPFR panel of the WKN Specialised Services Management Group, pending the establishing of a new collaborative commissioning leadership group. So I'll take those on block. Does anyone want to indicate that you don't approve that composite recommendation? So that is approved, and we are also asked to note the terms of reference for the CTM Audit and Risk Committee for hosted bodies are contained within the CTM ARC terms of reference, which are under review and will be presented to the CTM board meeting on the 26th of September for approval. But that's simply there for noting. Thank you. So just before we have a break, item 3.5 draws our attention to the minutes of our last meeting held on the 24th of July. Initially, for accuracy, would anyone like to suggest any corrections or amendments? No, so they are accepted as a correct record. We've already dealt with the action log, but are there any matters around? There is one specific matter arising that I will deal with just before the break, but are there any other matters arising that anyone would like to raise? No. So we have deliberately put this on. Hayley mentioned it earlier, which is the proposals in relation to the temporary service changes, the process for which we're currently going through. Colleagues will remember that at our last meeting, we reported that we were embarking on engagement in relation to decisions that we'd made as a board. Very quickly within that engagement process, and particularly in our conversations with CLICE, the Citizens' Voice body, what we heard was that there was very significant concern in relation to the process, the proposals. And so we took that very seriously. I believe that this process had integrity, and therefore we changed the process. We extended the engagement timetable, and instead of engaging on decisions that were made, we then changed that, and so we were engaging on proposals. So when we meet on the 10th of October, we will, as a board, be discussing the proposals that will come to us. We will have reports containing the findings and analysis and so on from the engagement exercise, and then it will be our responsibility then to decide whether or not we support those proposals or not, as the case may be. And so as a result of our listening and as a result of our learning, things change slightly, and we alter things accordingly. But that's really just in terms of an oral update in this public meeting, and we will have that very important and substantial item on our agenda for our additional meeting, which will be held on the 10th of October. So I don't have anything else to say about that today, and I don't propose that we open it for discussion or comment today, because we will be back for it. So that brings us to our break, and it's now nearly 1:15. Let's take the 15 minutes. We're just slightly behind schedule, but we'll reconvene at 11:30. Thank you. Croeso nôl, pob un, ac dyn ni'n parhau efo'r agenda sydd ger ein bron heddiw. Mi drawn ein sylw rwan at eitem 4.1, sef adroddiad ariannol. We turn our attention now to item 4.1, to the financial performance report, and we go to our Director of Finance, Pete.
Yeah, good morning, everyone. Thank you, Carl. So the finance report is included in our papers in the usual format. I will just take you through some of the key headlines and then we can open up for a discussion comment on the report. So this report is given the finance position for the Health Board as at month 5. So as a reminder, the Health Board has a £23 million deficit plan. Sorry, it's 22.9 million, but round up to 23 million. Just to note, as was raised earlier, that plan as of yet is not supported or recognised by Welsh Government, but the Health Board continues to monitor our financial performance against that deficit plan. As of month 5, we've seen a continued deterioration in our performance. We're currently 3.4 million off that deficit plan. If I reference you to the table on page 2 of the report, this gives you a breakdown of our performance against that deficit plan of 23 million. It shows the variance against that. You'll see from the table the items that have got a black number of variance include our pay position with continued pressure against our agency spend, our commission services position, which we touched on a little bit earlier, which relates to our services provided by other bodies and our spend in relation to continuing healthcare and funded nursing care. That has given us a pressure of 3.4 million. This is very worrying and very challenging. As a direction to all, we'd ask all budget holders to do what they can to reduce our run rate. And in particular, in relation to our commission services, there is an action plan that's been developed by Steve, the commissioning team, along with the finance team, which targets circa £4 million of improvement against our position as we move towards, as we progress over the next couple of months. Just in relation to that, it's going to be key that we monitor that performance. That will have a big impact on whether we can hold our current deficit plan of 23 million or whether it presents significant risk that as we move through the year. So month 6 is going to be a very important month as we then can understand if those actions are having any impact. If I continue on and then I'll ask Steve if he wants to comment around the commission services plan, if that's okay. Also included in the report, as always, you've got a breakdown of our provider position. That clearly demonstrates the pressure against pay. And as you've seen, the main pressure in pay is in relation to our mental health and LD services. And again, that's in relation to the use of agency. That agency will be in part to cover vacancies, but also will be in respect to higher levels of acuity and a need for increased care for patients. The commissioning position is included on page 5 of the report. As you can see, the breakdown of the current pressure to month 5 of just over 2.5 million. The main pressure area is against our English providers, with the pressure being in relation to increased activity from Robert Jones Agnes Hunt, whether their activity is 18% higher for the first 4 months of the year compared to last year. In relation to Wye Valley, where we see a considerable increase in our community hospital attendances and length of stay in those hospitals. And there's WISC, as we've already, the Joint Commissioning Committee, as we've already highlighted earlier in our meeting. We continue to track the impact of delays in the system. That's included on page 6. Clearly, this is one of the wicked problems for us. It's a system failure where we work closely with our local authority partners to try and resolve this. And this is an indication of a level of inefficiency that's included in our position and has an impact on our costs in terms of agency, our commission services, and ultimately can impact on CHC as patients are not discharged as quickly as they could be. Also is included is the usual analysis in relation to our prescribing position. This is an area where we have good financial performance and that's helping to offset some of the pressures already alluded to. Again, similar analysis for our continuing healthcare position. Just a reference again, page 9, this is our savings plan and delivery. A reminder for the board that we had an original target at the beginning of the year of 7.9 million. We then increased that target to 9.9 million, and that forms part of our £23 million deficit plan. As you can see against that target, included in the table on page 9. We currently have green and amber schemes totaling 8.5 million. Still a shortfall to close in relation to 9.9 million target as set. Our risks and opportunities continue to be as previously reported, so I won't dwell on that. But just really to summarise that the financial position is significantly challenging. As per the original £23 million deficit plan, that was already included a challenge of £9.9 million worth of savings and efficiencies. As of month 5, with 3.4 million off profile against that plan. So those urgent actions as referenced, those mitigating actions to improve our position need to be actioned straight away. I've referenced the commissioning plan, and we need to monitor that carefully to understand whether that will deliver the improvement needed to hold within our deficit plan as set. Very high level overview. Happy to take any questions or open up the conversation around any particular points.
Thank you. I will go to Steve now because I know that other colleagues. So, but Steve, I wonder, as well as commenting on the plan to get us back on track, as it were, in terms of commissioning, I wonder if you might just share some observations as to why we find ourselves in the position that we currently find ourselves, why are we off plan? So I know that we know the reasons in terms of the overperformance, but have we misjudged? Have the assumptions on which we based our plan been somehow not as they should have been? So just a kind of explanation as to why we are there.
Yeah, sure. And I'll probably theme these in terms of planned care and urgent care. So certainly from a planned care perspective, what we're seeing within the Robert Jones and Angus Hunt contract, for example, is they've undertaken a far greater volume of work in the start of the financial year compared to the previous months of previous year's delivery. When we've investigated what that is, they've purposely sought to front load a lot of their capacity during the year because they are now about to enter and are currently in a period where some of their flexible capacity is not available to them in terms of the additional capacity that they've been using to sustain that level of activity. So some of this is around then the nuance of forecasting and whether we should be altering, a straight line forecast for Robert Jones, for example, or taking into account in future months that no dip in delivery, which we will do in our forecast that comes through in the next iteration of this report for that specific contract line. From an emergency care perspective, what we are seeing is an increase in activity, a little bit more than we had planned for in terms of growth. But in particular, we're seeing an increase in the length of stay of those patients that's then generating additional charges. Now that is beyond what we planned for. And as Pete said, that's down to system delays. So, I mean, myself and Nina, for example, the last couple of weeks, we've been spending a lot of time with the Herefordshire system because we've had a particular issue over in that area. And the level of delays in that system is, again, higher than normal, higher than we planned for. So it's about then what we're doing about it. And then our confidence factor going forward to see if that level of activity and those number of delays will drop. If we take no action, obviously the position will worsen. And with obviously winter and the worst months of annual delivery to come from a winter pressure perspective, that will worsen significantly. So we've done some work with that system, which is paying off, but it's those sustained system responses that we need on emergency flow in particular to rectify some of the year-to-date positions that we're seeing. And similarly we've noticed with some of our providers in England, but particularly in Wales, where they've started to open more same-day emergency care facilities, and that is to prevent patients being admitted for more than one night length of stay to try and treat and discharge on the day. We're just seeing from a technical contracting and charging perspective, an increase in the amount of activity that is being charged to us as those new facilities have opened. So it's obviously the right thing to do for patients, but we're in dialogue with those providers to say, well, that's fine, but in the old days, prior to opening SDEX, for example, we wouldn't have been charged for this activity, but we now are. And for CTM, for example, we're seeing a 19% increase in that volume of activity. So we've rightly built that into the current year-to-date position because we've been billed for it, but we've put a number of queries into the system with CTM and others to say, is that a valid charge, and what are we going to do about it? And then if we can alter our forecast accordingly. So we've got in our commissioning recovery plan, if I can call it that, we've got a series of opportunities that we're exploring to reduce that year-to-date overspend and get that back into check. The other thing within the commissioning position, I've got a 2.4 million savings program. Now a lot of that is phased to deliver in the latter months of the financial year. So, for example, there's a particular scheme on reducing emergency admissions. That scheme has started, as I've just explained, but there's also a more significant scheme to reduce the number of patients that are currently out of county in English community hospitals. We've had some success in that. It was phased to start from month 5, so we are seeing a reduction in the number of health delays waiting out of county in English community hospitals, but we've still got some adult social care delays. And again, we're working as a system to try and reduce delays, because those delays in any sector, whether it's our patients in our own beds, out of county beds in Wales or in England, they are generating this additional cost to the commissioning budget. And as Pete rightly said, it's a sort of a quantified cost of system inefficiency, and that's what we've got to rectify. It is a challenging situation, but that's what we've got to do if we're going to bring this commissioning position back into check.
Okay, thank you. I'll give colleagues opportunities now to come in. Robert wants to come in, and then Steve Elliott.
Yes, I want to highlight the secondary care delays. Yesterday, we visited the board on Bronfleece, 18 beds, all full, but 9 of those were for patients who needn't be there, shouldn't have been there. And of course, it's not just the financial issues, deconditioning, socialization, and all the rest of it. And when I look at the information you provide, Pete, there, I think last year the cost of secondary care delays at the end of the year was about 5 million. Does that sound right? And the trajectory of this looks as if it might be 10, 11, I don't know. It's 6 million, and we're halfway through the year. So it's a very alarming increase. And I just like to understand, Steve, a little bit more of what it is we can or that we are doing to change this. Because the way things are going, it might even get bigger again.
Thank you. We'll take a few comments first, and then we'll invite Steve or whoever to respond. But we'll go to Steve Elliott and then to Nick.
Yeah, thanks, Steve, for the explanation. I mean, clearly there's a time lag, really, isn't there, between the information you receive and the actions you can take in terms of that feeding through into your position. And obviously time is of the essence here. So I just wondered what actions are being taken more generally across the organisation. Maybe this is a question for Hayley and yourself, Pete, in terms of identifying other opportunities to offset spend if we don't get the traction on commissioning that we're looking for, because clearly we are significantly over now in terms of our position against the deficit plan, and so time is progressing. A couple more questions from me, if you don't mind. One is, I think Hayley referenced the overspend coming through from the JCC. I believe it's paper later on that says out of a 10 million savings target, they've only delivered £800,000 to date. So to what extent is that feeding into the position being presented at the moment? And also in terms of pay, the pay position hasn't moved significantly this month, actually, in terms of the variance, although, you know, it's still flagged up as a significant concern. Are we seeing a turning of a corner in terms of that, or is it still an issue relating to the e-rostering system that has been reflected earlier?
Yeah, so would you like to respond? I think, yeah, probably, yeah.
So, yeah, if I pick up on that, help me, Steve, if I miss any of the comments. So the first one about what other mitigating actions can we take? I'll reference the risks and opportunities log as one part, but generally across the organisation, given that we're in a deficit position, given that we've got a deficit plan that's not supported, we've already instigated all the things around grip control in terms of vacancy control, where there's a vacancy control panel that reviews all jobs before going to advert and to maximise any opportunities there for savings. There's a non-pay review group which reviews all spend over a certain level to make sure that that is all appropriate and needed. So all of those actions are being taken along with a task for all budget holders to reduce their run rate as far as possible. So that is the position. There will be, you know, further asks for people to do everything they can. I think I will reference the board to those other options that have been previously considered around improving our financial position, which to this stage have been discounted. That's the reality and significance of the situation. So that's in respect to that one. In terms of the pay position, you're right to flag that little bit of a health warning around the system and making sure that that's all accurate and up to date in terms of the number of agency shifts worked. But we are seeing improvement. We are seeing an impact from the actions being taken as part of the variable pay group, particularly in the community services group, where we're seeing that use of agency reduce. That is linked to some success in terms of recruitment, but also some other actions that have been taken. And we are expecting to see that improvement in the mental health and LD area too, and we're just trying to track that for the remainder of the year just to understand what that improvement will do to our position, noting that we had a target to improve against our agency spend as part of our plan. So we're working through that. Did I miss JCC? Yeah, JCC.
It's contributing 254,000 year to date overspend within the month 5 position. When we pick up our share of the overall JCC financial position. If I may, Chair, I'll respond to the other question then. So Robert, in terms of what we're doing about delays, I guess it's really important to say at the outset, you know, this is a whole NHS problem right across the UK in terms of delays and patients in the wrong place, so to speak. There's no shortage of oversight within the health board and with Paris County Council. So colleagues meet daily. We've also got a weekly joint chief exec meeting with Paris County Council, chaired by Emma from Paris County Council and Hayley. That is developing a rapid action plan because we see the absolute importance to reduce delays. It's also subject, obviously, to external scrutiny. The number of package of care delays are monitored and reported on a weekly basis. But I think it's going to be pretty challenging to turn the position round. But that doesn't mean to say we can't do it. I don't know whether Nina, you wanted to come in on some of those delays, in particular the system working.
Please do, Nina. I've got some other colleagues that want to come in. So, but you do add to that, and then we'll go to other people.
Thank you, Chair. And I did have a question as well. So if you wanted me to bring that
Please, take the floor.
Yeah, no, I appreciate the chance for an opportunity offline to discuss the reporting and how that comes forward for you as a board in terms of secondary care delays. But I just want to say that, you know, absolutely, we're working really closely with colleagues from Powys Teaching Health Board and increasingly the third sector as well, what we can do around supporting this whole system delay and a whole system problem. And it really is very, very challenging, you know, adult social care, health, joint delays, etc. And the impact that has, and it's not just financial, obviously. I know we're discussing it as part of the financial, but the impact of it is very, very significant, isn't it, in terms of the outcomes as well, which is really important. So as Steve said, you know, there's daily meetings between our teams. We are having weekly escalated meetings now, including the chief executives of both organisations. And we're looking at short, medium and long-term actions together. And that's really important as well. So because we've got to change things long-term as well, but that's going to take time. So it's really important that we also focus on the immediate short-term actions as well. So just wanted to give you that assurance that this is absolutely a key priority for myself, for my team and for the council. And if I could move on to my question, if that's okay. I know within the report, the 24-25 financial plan provided for CHC at a consistent, a kind of flat position. And I think my query around that assumption is with the demography of Powys and the ageing population and the increased demand and complexity that we know we're seeing, is that assumption still correct to be having a flat position in CHC and FNC, for example? So just a query, thank you.
Does anybody want to come back on that particular query before we go to other colleagues?
I'm more than happy to come back on that. So I think there's a couple of things on that. The first thing is we're doing some work at the moment with public health team to look at the demographic impact on CHC and FNC locally. And I'm involved in a national work stream where I've asked for that work to be done nationally as well to understand that picture. But clearly, one of the drivers is the number that are eligible. And we've had, as a health board, an internal audit which says that a process for doing that has been really strong. But the issue for us is the cost of those packages are increasing exponentially. And there's a particular issue for us locally about our ability to place individuals. So it's not a straightforward sort of answer really, because we do need to do some further projections around the expected demand for CHC, but it is increasing. But what's really driving it is the cost of the packages and our ability to do that. So we've had some deep diving committees. We'll be able to bring back further report once the public health team has completed that piece of work. The other issue I just wanted to raise is the Welsh Government position on this. So, you know, clearly Robert at the start, right at the beginning of the meeting, asked about additional requirements. What is absolutely crystal clear so far, until we're informed otherwise, is the expectation from Welsh Government that every health board in Wales delivers its plan and its performance trajectories. And that is the basis on which the overall balancing of the minimum expenditure group across Wales has been based upon. Now, we've got to remember that we moved our plan in May to offer an improvement of 2 million. And we're still working through some of that, I appreciate. And in particular, we are engaging currently on some temporary changes, which is a small fry financially, but actually all these changes will help us to think about how we move forward in that sustainable space. So Welsh Government have been really clear with us in our correspondence that the board fully understands the financial position, first of all, and our reporting has been, we've had feedback that it's strong and there's a clear collective ownership of board, the financial position, and clearly that we can articulate clearly what the cost drivers are. So that point you raised, Carl, is why are we off plan? How we're able to demonstrate that really clearly is important. And we know we talk more generally continuing healthcare agency spend, but also, you know, the impact of the flow position, which is a whole system issue which we need to, in a multi-agency way, address, really driving additional expenditure due to the length of stay of our patients, not only out of county, but also within our own community hospitals. I think that the issue around the action that we agreed in May, which were difficult, was around repatriating patients back from our English district general hospitals as quickly as we can. You hear also the work that we've had to put in place as a system the last few weeks around Wye Valley Trust and the particular issues there. So we are struggling operationally at the moment to deliver the ambition that the board set, which is about earlier repatriation of our patients from English community hospitals. The other issue, and I suppose I'm focusing on the problems at the moment in the JCC space, the Joint Commissioning Committee I was at last week, we had the latest detailed discussion about the financial position. And Steve was quite right in referencing the non-delivery of savings against the 10 million being substantially off track. There's been some additional mitigating actions that the finance team and the JCC have identified, which brings that current projected overspend to 5.6 million. But that's in the context of health boards across Wales having, for example, placed a 4.45 average uplift to that position. So there was a very clear discussion in JCC last week. We have got to identify additional mitigating actions in order to bring that down further for the whole of Wales. Because the reality for us as a health board, we cannot compensate for the overspending in commission services in secondary and tertiary and emergency care by all dealing with it as a provider. It just cannot be done. So we've got to actually look at it across the whole system. And I share that because it's really important that we're not under any illusion that we can make it up completely through the work that we are responsible for as a provider. We have got to get improvement in secondary care and in the JCC space in order to bring us back into forecast. So it's about where do we focus our effort and energy as a team, which is where we need to be very clear about. It's the JCC space, it's the secondary care commissioning space, as well as getting better efficiency and productivity and flow across the whole system in Powys. I think that I wanted to just mention two things. One, which is around the additional targets. This hasn't come forward to board yet because we only met as a regional partnership board last week. But the Care Action Committee has set additional targets for the whole system to deliver over the next few months. And that is particularly focused on pathways of care delays. And we are currently working in a multi-agency way to update our winter plan and our system forecasting around how can we hit those targets. And they're not going to be easy. It's things like access to district nursing and palliative care over the weekend. It is also about a substantial percentage decrease in our pathways of care delays. But actually, we need those to recover the financial position. So we've got to push our energy and effort into that. And I think the final point I wanted to raise was around, I am really very aware that in the board today and in Pete's sort of presentation, he referenced about our need to look at the end of year forecast as a collective board. I think next month, month 6, is a really key point for us, as Pete explained. But I'm also very aware that straight line forecasting has its risks, because we know there are a number of factors at the moment that have an impact on that, not least winter, not an emergency pressures, but also the context of the Minister having clearly set for the NHS the need to improve 104-week waits across the whole of Wales, and that being a key priority for us across the whole system. So I'm mentioning those two elements because what we need to do is ensure that our assessment of the forecast is clearly done at month 6. But the methodology and approach we take to that, we need to be clear on how we're going to take into account both our financial position and the response we've had from our commissioners with regard to some of the contract challenges, as well as our expected performance trajectory over the last 6 months to a year. It's not going to be straightforward, but our job will be to get us to forecast. So it's, it's continuing those actions at every level, not pretending that we can mitigate all of that financial risk simply by dealing with it as a provider.
Thank you, Hayley. We've got a number of colleagues that want to contribute. So we'll take a few contributors. So it's Mick, Simon, Ronnie and Kirsty.
Thanks, Chair. I think most of the points I wanted to make and the question I want to ask have just been dealt with in the last conversation. So just a couple of points to add to that. I want to make the same point as Robert about the impact of delayed transfers of care, delayed packages of care. Steve and I spent some time over the last 6 months kind of around the patch talking to people, and we've said to people as a board, what could we do that would make a significant impact? And that issue of delayed transfers of care comes up repeatedly. But it's not just the financial impact, it's not just the impact on performance, it's also clearly having an impact on staff morale and staff well-being. There's a sense of helplessness almost. And I got a sense of real kind of collaborative effort between health and social care to try and address these things. But it is impacting on people's confidence and their morale. And so it's much deeper than money and performance. And I was looking for reassurance really that as a board in partnership, we were really focusing on what could be done locally to try and improve the situation rather than relying on national solutions. And I've heard that. So that's quite reassuring. My other question really was about the position that we are still maintaining that we've achieved end of year balance. So my question was, well, when do we seek? When do we question that? What's the rationale for doing that? I think Pete and Hayley have answered that. So I suppose the last question I had in my mind was if the worst case scenario happens and we don't get strategic cash support at the end of the year, what happens then? So what happens in February, where whilst government maintains its position, we've not been able to recover the position, and we end up with 6 months with no strategic cash. But I know it's the unthinkable, and it's never happened yet. But what if it did? What would we do?
Thank you, Mick. We will hold on to that. Those really important questions. But Simon.
Thank you. Simon Wright, independent member. A lot of it has been answered, but I came into this item really thinking about the credibility of the board with Welsh Government and with an awareness of a strong, credible history of delivering on the financial plan, and a concern we're roughly halfway through the year, we're some way off. Have heard some things that have reassured me around it's not a straight line trajectory, that there is work taking place. So it has been said, I think it is absolutely critical that we deliver on our plan or are able to explain clearly what has varied in our assumptions on the plan. And I have done quite a lot today, which has given me some reassurance on some of those points. But I think, like other board members, a real sense of nervousness about how far into the year we are, how big a challenge we've got, how big the bill is on the delayed transfers of care. And whilst there is partnership working, we have been told that for several board meetings that is in place, and it doesn't seem to be changing the dial. We're not hearing anything new that is changing to shift that dial. So it's just a sort of point of criticality about our own credibility with Welsh Gov, and to really be looking at that local set of actions. And I don't know how much more capacity there is in the system to ask for a renewed figure on it, but it does feel that we really do need to be working with our partners to do everything we can to unblock. And also just to ask, the transformation work does strike me as providing some help in that space. And how far are we clear in articulating that part of the focused work that will enable better focus on the transfer of care challenge as we move through those temporary changes, and how we measure and capture those impacts as we implement those and talk to our public about those things.
Thank you, Ronnie.
Thank you. Mine's a slightly different question, but I do have an equal sense of nervousness to Simon. If I go to page 5 of the 18th page report, service with the largest overspend is mental health, predominantly due to increased agency and locum expenditure. I just like to try and get underneath that a bit. Is that provision of medical cover or nursing cover? How does that break down? And I asked that question quite deliberately against the background of the internationally recruited nurses that usually reference this movie, all of whom I will say, from the Nigeria, on behalf of all of the board, they're all very welcome. But I just like to be clear to what extent they're competent in provision of services and mental health. And if we are having further cohorts of internationally recruited nurses, will that give us further relief in terms of local expenditure on mental health? And the other thing that I will say is, I just have a sense that we're talking about figures that are coming in month 6 and making decisions on the basis of that. And I suppose my question is, are there any decisions that we should be taking now slightly upstream of that, which would give us increased confidence for our month 6 position? Thank you.
And we go to Kirsty, and I just want to just get a sense of whether anyone else thinks that they might want to come in, because I think it's a really, really important agenda item today, and I don't want to stifle conversation and discussion that is appropriate, but equally, I think we can make up some time on future items on the agenda. But okay, I'll bring Kirsty in. We'll invite executive colleagues to respond, and then we may well then just move to the recommendations. But Kirsty, please.
Thank you. First of all, to look at the issue of variable pay and noting, the figures and the health warning around some of those figures about the level of confidence. We've heard a lot about the various work streams that are going on to look at variable pay, but I was struck by the comment that we are still in the area of going to off contract to fill shifts. And I just do wonder, one thing I've not heard about is whether we're really scrutinising and whether we're really optimising our own bank provision and the effectiveness of our own bank, both in terms of how our staff can engage with our own bank and how easy it is to do that, and the effectiveness and the efficiency of our own arrangements. And I'm raising that because we don't tend to hear a lot about that. And I'm just wondering if that's an area that is really being looked at and whether we are optimising that. And then to the issue around delays, I mean, what's really worrying for me is that we're now seeing delays not just in what we've been reported in our own beds, our English providers. We're now seeing delays in mental health as well, and we haven't seen mental health delays for a long time, but we are now seeing delayed transfers of care in our mental health services, which I think is demonstrating a deterioration of the position, that we're getting more services that are finding themselves in this position. And Nina used the phrase, this is not for a lack of oversight, and I absolutely see that. I can see everybody's working really, really hard, but it's a lack of something, isn't it? Because if it's, if we're getting all of this oversight and we're still not shifting, then there is a lack of something. And I guess for me, my question is, speaking to Simon's point, what else are we going to do? And what are we going to do differently? And what is there a lack of? Because it's not a lack of understanding, it's not a lack of effort. So fundamentally, what is it the lack of, and what are we going to do about solving that lack? Because the position is getting worse, and with all the consequences. And I couldn't agree with you. On Investor Governance yesterday, again, speaking to the person in charge of the ward, what's the thing that's keeping her awake at night? And it is the constant struggle and the the draining effort that is going in to finding, care packages and getting people out to the hospital. And in that case, the Newbury Police Security was the Talbot Council they couldn't get hold of, because we've got patients from across the border in our beds, and they said, we just cannot get hold of the people we need to get hold of to be able to move these patients into where they need to be. So I think that's a really important point to make about morale. And then I've heard about forecasting. There's a hint here that we may need to get to a change in our forecast, and I understand why we need to delay that and when that will come. But the question I've got is, Pete, at what point do we have to revisit the things that we've already brought out? And we ruled them out for very good reason, but with this far into the financial year, this seriousness of our position, at what stage are we going to have to bring those things back onto the table and re-engage in a discussion about doing things that previously we've said we would not do? Because if we can't make it back on the pay, and there's no obvious plan for making it back on the delays, then those things are going to have to come back to the table. So when will that be?
So a lot in those contributions, isn't there? Obviously, we can't, this really could be a discussion that could take us, could take a very, very long time. And I know that some of this will be focused on and discussed outside of this meeting in various arena. But I clearly, Hayley, Pete, colleagues, you will want to respond to lots of the things you've heard.
Yeah, so I'll try and pick up all the points made, and then we can mop up if that's okay. Carnage or Hayley will come in. So the first point I want to make is around the forecasting. Our forecasting is not as simple as just divide by 5 times 12. It is more sophisticated than that. But as Steve explained, there's a myriad of factors which have to be built in. So at the time, it's always the best forecast we can have. And what we're waiting for is to see the impact of some of those actions to then inform the forecast. Just wanted to make that point. I think around the timing of when, Kirsty, I think we're pretty much coming to that now. But that again is a board collective decision to talk about that. But the impact of the actions we reference will be very important. So just moving through in terms of mixed comments around strategic cash. So at the moment, we submitted a deficit plan of 23 million. As is ongoing conversations, the assumption may be that there's recognition of that from Welsh Government up to that point, but beyond it, I'm not sure. So it is a risk. So your point raised is important. If it was recognised, we would then get that strategic cash support for that recognised deficit. So it's a really important flag to make. In terms of the comment from Ronnie around mental health, there is a mix in there of medical and nursing cover. There has been some positive news around the medical side of recruitment, so that should hopefully improve that position. And there has been some ongoing action in that area around the nursing position as well. So as I referenced, we're expecting to see some benefit. Again, that will be reviewed and updated on an ongoing basis. Kirsty's comment around the bank, the process is bank first. Well, no, it's actually, can the team reorganise their shifts first and then bank and then moving up? And we've been talking in the variable pay group around how can we encourage more to join the bank. We've talked about, can we sort of automatically enrol people on the bank if they're happy to be on when they start with us. So again, we're looking at how we can make the bank more effective and more attractive on an ongoing basis. And obviously Deb's not with us today. You could have added some extra comments onto that. I think then when it comes to we're going to off-contract agency, that obviously is the last resort. But at that point, it's about maintaining capacity or not, and that's what it happens. So it's that simple, and I know you know that. In terms of Welsh Government understanding our position, so we've obviously submitted our plan. We've obviously had an iteration of that. There's ongoing dialogue. As part of our escalation status, we're working through a number of our financial plan factors with the financial performance and delivery group, so that understanding our position, clearly we all know that the financial pressure is a byproduct of the demand and capacity in the system, our workforce availability, our rurality and the demographics of our population and our workforce, which all will feed into that. I've absolutely not done it justice in that short sentence, but that is the factor. So that understanding on where we are and what is our sort of the best we can do to deliver the health for our population and minimise that financial impact has been something that we've been in regular dialogue around. So they were the key points I noted. Carl, if I've missed any, please let me know, and then Hayley may mop up as well.
Yeah. So yeah, I think it's a really important description of it, but I think we might, in the light of the time that this is taking, quite rightly, quite justifiably, we may just need a bit of a conversation as to how we deal with the rest of the agenda for today. But Steve.
Yeah, I think there's been some rightful conversation about the plan. So was the plan set on the right parameters? Was it heroic and so on and so forth? So, I mean, clearly it was a plan that's been built on a set of parameters, both for finance, performance, quality, and some of our other deliverables. So I think the plan was built in a sensible, deliverable way, but clearly some of the parameters are, some of our actual expenditure drivers are clearly higher than we planned for. There is still 6 months to go, so there is still time to take action to improve the situation. We're not having this discussion in February, we're having it now. So all is not lost in terms of improving, but there are obviously significant challenges, as we've said.
Okay, Kate wants to come in, and then we will go to Hayley for a final contribution.
Thank you. So yeah, so much. I think we'll probably predict what I'm going to say, but it's just to kind of really raise that the finance is significant, but especially around the detox, then the harm and the quality is really concerning. We know that there is harm. There's very good evidence of harm with delayed transfers of care. And so for me, I'm at every bit, I think what we can see, we've talked about oversight, there's a huge amount of focus on it, what that tells me. And I think there are bits that are probably not within our gift, bits we can't control, but there are still bits we can control. And I think the fact that we've spent, as long as I've been here, really staying very close to it and we're not really affecting change, tells me we haven't got an efficient system. When our system, we've got good staff who are trying their hardest, but our system isn't working. And so I think doing the same isn't going to, I know doing the same isn't, and I think we know that isn't going to affect the change we need. We need to do things differently as a system. Some of the things are the system around us, and that's difficult. We need to challenge, but I think, there are some things that are still within our gift, but we need to do things differently to get there. And that's not, it is about the money, but it's more about the quality and the harm that we know people will be coming to because we're not running our system as efficiently as we could.
Finally, Hayley, and as succinctly as you can.
Yes, okay, so Kate's really covered one of the key points around doing more of the same. Our staff are working really hard across the whole system. And part of the conversation that we need with stakeholders, partners and the public is understanding the current system in its current state needs fundamental review and change. This is about systematic and fundamental change. And I think how we do that and learning from this process of engagement we've just embarked on around temporary changes is going to be really important. And the point that Linda raised earlier about that join up between a sustainable Paris, ourselves, but also the wider system, the third sector and other providers is going to be key. I don't think anybody's mentioned so far acuity and referral and actual activity. Yeah. So because of the position we find ourselves in, we are still seeing a large number of patients, generally speaking, increasing activity and increasing acuity. So although we will look at variable pay and some of the staffing costs from is it medics, is it nursing, is it off contract, is it bank? What's really driving some of this, particularly in the mental health space, is the clinicians are telling me that people are more unwell and they need higher levels of specialling, and that is generally the feedback that we're getting around that. Also, the referral rates are going up and the activity pressures is a factor. The other issue in mental health I would reference is, yes, the deterioration around delayed transfers of care it is noted and of concern, but also our use of mental health out of county providers has increased substantially as well. And there are a couple of reasons for that, but one of the key issues is the bed base in Blyndre has been reduced over a period of time, and that has had a knock-on effect on our spend profile. We're spending it in different places in the system because the patient need hasn't gone away and these patients need to be treated and looked after. The issue around the bank is a really interesting one because I'm going to take that for a further discussion, Mark, and Deb is not here today because I think we've had feedback previously about bank and the efficiency and effectiveness. And for example, if you recall, we brought in things like weekly pay being available to staff who work bank shifts, and direct feedback from staff that would really help. Reality of uptake on that suggests it's not having the impact that we were looking for. So I think this an action for us to further look at that and bring it back to the Workforce and Culture Committee. And then the final issue is about escalation. So I'm quite clear that the current escalation status of our organisation is enhanced monitoring on the basis that we were doing our plan in relation to all the aims. Finance is only one, performance is another, quality, access, etc. There is, if we continue on this trajectory, we will also potentially face a scenario where our escalation status will increase and the additional scrutiny and requirements that will bring to us as an organisation as well. And I know that the next sort of round of discussions around that through the regulators, Welsh Government and other colleagues is planned in October. So I'm just, for me, hearing words like nervous, Chair, and concern is appropriate. This is really concerning, and our collective board efforts to take additional actions, even those we may have discounted in the past, will be something that we will need to do. But I'm back to the point of we need to do that across the whole pathway of care, not just in our provider role.
Thank you, Hayley. Yeah, really important discussion. I think it's absolutely right, Hayley, that we that we articulate the various perspectives. You're absolutely right. We have heard the nervousness around the table. I would even say that we've heard the discomfort and dissatisfaction around the table. And I think that's absolutely right, important and proper. Also, we've heard, of course, appreciation and recognition of the important work, the good work, the impressive work that's being done by ourselves with our partners in very, very difficult circumstances. And you're absolutely right. It's wider than Paris, and so but nonetheless, we are where we are, and as you said, and as Sadie and others have said, we still don't have a supported plan. And I just think we need to hold on to that fact. Welsh Government is still, we haven't had any other formal message from Welsh Government other than your £23 million forecast is not acceptable. You need to go further. But we're in a position where we're saying that that 23 million is possibly, probably not even achievable, and might even become 12 million or so more. And so, it's not about being driven totally by the money, because we know that could in and of itself create difficulties. But, that's the sort of the discomfort and so on. And I think coming back to Mick's point, Kirsty's point, other points, it's about, if the strategic cash isn't on the table, when do we consider the unpalatable? How do we consider the unpalatable? Kirsty's point, you know, the great oversight, but what's actually going to change the dial? I think it's been a really important discussion. For that reason, and you know, you may disagree with this, and if you do, that's absolutely fine. I'm actually going to suggest that we make a slight amendment to the recommendation to this item. The last bullet point of the item asks us to recognise that pending the outcome of the urgent action plans initiated to address the increased financial deficit, a revised year-end forecast may need to be considered. Now, actually, that's factually correct, and I'm not suggesting that. I just don't want us as a board to give the impression that we are complacent about the fact that, well, if we can't do much about this, we'll just change the forecast, and that'll fix it. Because that's not the position that we need to begin, it seems to me. We currently, as we meet today, are expected not to deliver the 23, but to go further than the 23. And so I don't think it doesn't feel right to me that we simply include in our recommendation that we actually might need to make the 23 worse. Now, but I do accept the reality of the situation. I'm not challenging the reality. So my suggestion is that we just make a slight amendment, but an important amendment, that the amendment, the last bullet point reads, to recognise that pending the outcome of the urgent action plans initiated to address the increased financial deficit, further options may need to be considered, so that we're clear about what the current expectation is, and then we are clear that the options are wider than simply changing the forecast. Now, does that make sense? And do we as a board, does anybody want to comment on my proposed amendment?
Could you repeat that again, please, Carl? Thank you.
So
just the revised and proposed.
Essentially, I'm suggesting we replace the words "a revised year-end forecast" with "further options." So the full bullet point reads, to recognise that pending the outcome of the urgent action plans initiated to address the increased financial deficit, further options may need to be considered when finalising the month 6 financial position.
I support that.
Is that?
Let's support.
Okay. Does anybody want to not support, or because please do. Okay. Thank you. Again, as I say, really important discussion. So I put the recommendation to us, 3 bullet points: that we receive the financial report, we take assurance that the organisation has effective financial monitoring and reporting mechanisms in place. We consider, and we have considered and discussed the financial forecast for 24-25 and the underlying deficit. Then the amended bit of the recommendation, that we recognise that pending the outcome of the urgent action plans initiated to address the increased financial deficit, further options may need to be considered when finalising the month 6 financial position. Would anyone like to indicate that they don't support the recommendation? Okay, thank you very much indeed. Rightly, properly, that has taken more time than we had on the agenda for it. And that, as I say, I do think that was absolutely the right thing to do. I do also want to welcome David and Nicola, who are here for the presentation on planned care. And if you'll both forgive me, we do need to just rejig our timing of things. So we did have 20 minutes for this. If we could do it in 15 minutes, that would be really helpful. And then, so we'll take that first. And then my hope is that not that it's not important, but the integrated quality and performance report we may be able to deal with quite exponentially.
Yes.
Okay. David, Nicola, over to you.
Thank you, and I can see colleagues people a presentation on. I'll allow Nicola to introduce herself properly, but Nicola's going to lead us off, and thank you for the time you've given us to present. I guess probably a bit of an oversight of some, I would say, some successful work that we've undertaken in our planned care team.
I'm Nicola Kelly, Senior Manager for Planned Care, and thank you for inviting me here today. It's a pleasure to be able to present the work of the Pan Powers Planned Care team. This presentation has been put together by the team, and you will see throughout it photographs of the various team members in their working environments across Powys. Next slide, please. So I'm sure, as you're aware, the planned care team consists of a range of different staff groups: nurses, admin, healthcare scientists, operating department, practitioners, clinical endoscopists, all working with our visiting consultants to deliver and develop services across Powys for our patients. And we've done a lot of work recently in terms of the workforce in outpatients, particularly over the last 2 years. We've developed a senior nurse for outpatient development post, and she's been really busy in terms of supporting the staff and developing roles to support a multidisciplinary approach for outpatient care across Powys, looking at how we can develop and train staff in the workplace to ensure that they've got career pathways within Powys so that we can retain our skilled staff within Powys to support our patients. So we're really keen to work through a multidisciplinary approach with partners across Powys, and particularly with the third sector as well. Next slide, please. So I've picked out here an example of some of the developments that we've undertaken, particularly in North Powys. We were really fortunate to be successful in terms of a bid to Welsh Government for outpatient transformation funding, and from that we've been able to recruit and train a number of different eye care posts. So we've now got an eye care infrastructure within North Powys, which matches the infrastructure that we've got in the other areas of outpatients in Powys. And we've been able to introduce a scanning diagnostic service into the ophthalmology clinics in Powys, so that the patients have a one-stop shop where they can have their scan and see the consultant at the same time, and the consultant has got those diagnostics there ready, to be able to interpret to support the patient. And that's really supported patients. They no longer have to travel to the DGH for that care. And we've been really fortunate that across Powys, particularly in North Powys, we have been supported by the League of Friends in terms of some of the equipment there. Well, we're really grateful to the support that we've been given from the third sector, from the RNIB. We've got a really proactive eye care liaison officer there who's an integral part of the MDT. So that's a really nice bundle of transformation that we've undertaken for our patients. And now we have the infrastructure. There's opportunities there for us to work with neighbouring health boards to bring back some more services for eye care, such as wet AMD. So we're currently working with Howell there to look how we can deliver a nurse-led wet AMD service into North Powys. So that's a fantastic bit of transformation. Next slide, please. I'm just looking across all of the different areas within North Powys. The team is now able to support an MDT approach, and we've been piloting a number of different clinics within areas across the north of Powys. In Newtown, we're currently piloting a colorectal clinic with Howell, which enabled the patients to be seen within Powys, and that will enable us to develop further services in terms of specialist nurses to support those clinics, so that more of the care for patients can be developed and delivered within Powys. And again, we've been really fortunate in terms of some of the third sector support we've had and opportunities that we've had in terms of funding that. So there's a number of different developments across North Powys, and we're really keen to utilise the space that we've got there to continue that development. within that area. Next slide, please. We take our patient feedback really seriously. We have lots of really great positive patient feedback, but this is just a demonstration of how we've taken some feedback following a concern to work with the POWIS Learning Disabilities team to develop a bundle of information and support for patients with cognitive disabilities to enable them and assist them to attend our clinic appointments. And this has been picked up by colleagues in Welsh Government as an area, a bundle of care, a forward outpatient bundle of care that could be rolled out across Wales. So just wanted to demonstrate the innovation that's been undertaken within POWIS by the team. We've just recruited a waiting well team, a clinical team who will be able to support our patients whilst they wait on waiting lists, and also enable us to view the patient journey through the patient lens, which will enable us to gather more information about the patient pathway to support further development. And it will also support us to liaise with the consultants and enable patients to make decisions about their care pathways and areas such as CON symptom and patient initiated follow-up. Next slide. Next slide. I just wanted to demonstrate the improvement that we've made in terms of gynecology. Historically, the colposcopy service has been consultant-led. We've now had the opportunity to develop a nurse post for this particular service, and we're currently in the process of recruiting into that post. We've been able to train nurses to undertake nurse-led clinics around pessary and just being able to develop the whole approach in terms of gynae, and we're looking to further developments around one-stop shops for that particular specialty as well. So there's a huge opportunity here with the infrastructure that we've got to develop services further. Next slide, please. We do get really positive patient feedback, and as I said earlier, we're really keen to use that feedback to develop services. Next slide, please. And just the infrastructure that we've got has enables us to enhance our liaison with consultant groups and to really develop and enhance our quality and safety processes and protocols within planned care. And we're now able to partake in some of the national databases that we weren't able to support previously. So it's really enabled and unlocked a lot in terms of the outpatient delivery. Next slide. This is a photo of the theatre team. So I'm just going to move on and just give a quick update in terms of theatres. A similar theme, a lot of work has been undertaken with the staff, just understanding roles and responsibilities, developing a leadership role. So we've now got a senior nurse clinician for theatres and endoscopy who's been able to review job descriptions and develop specific roles within the theatre and endoscopy team to ensure that our services are more efficient and that we're able to provide enhanced support to our patients. So this just details the different roles that we've been able to develop within the service to support patient care and to ensure compliance with our JAG accreditation. Next slide. Next slide, please. And we're really keen that we embrace any opportunities for digital healthcare within the service. So we've had a number of developments. We're now able to electronically track endoscopies through the decontamination system. We've got in place a scan for safety system, so we're able to electronically trace consumables from the stock room to the actual patient care. So we know when consumables are used, where they're used, and that helps in terms of quality and safety and audit. And also with the stock control in terms of making sure that we're only ordering when we need those goods. So it's able to ensure that we're efficient financially as well. So we're really keen to embrace any digital health developments within the service. Next slide. And just we're really keen to maximise our fantastic environment within theatres, and we've done a lot of work in terms of the Getting It Right First Time programme, and we've been able to further develop our processes. We've been commended for our approach to bilateral cataracts and the volumes of bilateral cataracts that we're currently undertaking, and we're just really keen to develop services in line with the best practice nationally. And underpinning all of this is our clinical admin team, who cover everything from reception to booking to liaison with the in-reach consultants to the management of health records. And I think it's really important that you know that they're part of this presentation as well. Next slide, please. And we've been able to develop a number of different posts within the admin team recently, cancer tracking posts that helps us to understand how our patients are moving between us and the DGHs in terms of their cancer care. So we're able to support patients across that process. And we've undertaken a lot of work in terms of the booking. All of our patients are partially booked, so they get a telephone call to agree their appointments, and we've also got a text reminder service in place. So we're really keen to develop the clinical administration team to support the work of the planned care department. So that was a really quick run through the developments within planned care, but there's lots of opportunity, and there's opportunity to manage referrals in a different way as well, using a multidisciplinary approach, so that we aren't so reliant on those in-reach consultants working with them, but there is so much opportunity within planned care.
And if I could just add to that, so obviously, it's great that Nick can bring this, but to bring it to life, if colleagues ever did want to spend some time with any of our theatres and outpatients teams to see if there's good work in progress, they are of course most welcome.
Yeah, well, thank you very much, Nick. Very impressive, if I might say so. Quick run through of what was, a huge amount of information, and I'm really, really grateful to you for working with in that way. I will open it for discussion or comments or questions. Does anyone want to come in? Okay, so we've got Steve, Mick, Ronnie, and then Steve. So Steve, have you got a question?
Thanks. Just two things. One, great to see the work you're doing on outpatients around learning disabilities and making that more accessible. That's really important. You were kind enough to show myself and Nick around the theatre in Brecon a few weeks ago, and one of the things you pointed out then was the opportunity maybe to offer out that capacity to other health boards, and given the sort of requirements from Welsh Government in terms of waiting times and that could possibly do with our financial situation. I just wondered if there's any more progress and anything you can do more to use that great facility more effectively.
It remains a challenge, as you might expect. Our health board partners, of course, are probably in a similar position to ourselves in terms of their capacity and resourcing, and that proves to be part of the challenge. We're constantly working with the teams in terms of expanding not only the provision for Powys patients in county, but also allowing them to expand their capacity over the border. And certainly that's our objective, but it will be a slow iterative approach.
We're good. Well, let's take a few. Let's go to Mick, Ronnie, and Steve in that order.
Thank you. I'm conscious Steve and I are dining out of our induction tour of the county.
Yeah.
we've seen many of those things in action, actually, as you said, David, and you know, it's really impressive. It's great to see the energy and enthusiasm of the people who are providing them. We can recognise many of those people, which is great. And one thing I left with was a sense of the extent to which the capacity that's there only gets used infrequently. So, you know, people say, well, that room is used on a Tuesday when a consultant comes over to hold up, or this is used for our monthly clinic here. And so we've invested quite heavily in you know, into facilities and estate. And I just left the question about how are we utilising it to best effect? I suppose if we were a business, we'd talk about sweating our assets, wouldn't we? So do we understand that? Do we know what the level of utilisation is, and are we making the best use that we can by thinking imaginatively about a different way of doing things rather than everybody having a little space that they go to on a regular basis?
Thank you. Let's begin. So, Ronnie, please.
Thanks. Very helpful presentation. Thank you. I enjoyed it. I'd actually like to have it in its fuller extent as well.
Yeah.
But what I wanted to say is, and you'll not be surprised even when I ask this question, where are we in relation to JAG accreditation? Has that taken place yet? And secondly, you put a lot of effort into making all of this system work. What does your DNA situation look like? And here I guess you're heavily dependent on your bookings team to make sure that all of those available slots are used. Thank you.
And Steve.
Well, thank you, David and Nicola, for the presentation. I thought it was great, and it's really more of a comment in terms of you know, this morning we've talked a lot about a lot of sobering issues, financial position, and some of the challenges around urgent and emergency care and delays. I think it's really important that we bring through those positive aspects of the NHS, because these services, you know, the positive service transformation change that the team are doing, and you know, it's really important that we continue that work. Given but against those obvious challenges that are in the system. So just to sort of, I really wanted to say that because it's good for the team to hear that.
So do you want to respond, either of you, or to the questions or comments made?
So in terms of the DNA rate, that's really low in Powys. It's generally around 3%, and that is a lot to do with the efficiency of our booking systems, and also patients do get a clinical call as well just before they come into clinic to ensure that they understand why they come in, the importance, and any support and guidance that they need. So we're really fortunate in Powys that the DNA rate for planned care is really low.
I'll pick up the utilisation again in terms of yes, we do work with, again, some of those other agencies. We are beholden to when those, for example, consultants want to operate their clinics, and often trying to move one to then accommodate others proves to have so many knock-on challenges. So yeah, we have a pretty good understanding of our utilisation of theatres and our outpatients. I'll come back to outpatients in a second. We do quite a lot to work with health boards about how we can maximise that interoperability, if you like, and make sure that we use the space effectively. Outpatients, a bit more of a challenge, not least because the booking systems, they're all paid per. We are moving to an electronic system, and there is a small project going on within the efficiency of the team to try and work out how we improve what essentially is the coordination of all of those rooms, but that's going to take a bit more of our digital development, and colleagues in the digital team are helping us with that. And then JAG, yes, there has been some progress, recognising that, so there is a re-accreditation visit that is due to happen 6 months after the original, and we are putting all the preparation in place for that. The key area for clinical leadership, where we were challenged, we are continuing to work with TAF in terms of their plans to support us, but colleagues have now actually secured a named clinician from a different health board who is willing to support us within the endoscopy team. That is being contractualised as we speak, and therefore we fully expect to be able to be as successful as a future reaccreditation visit.
And Mick's point about sweating the assets.
Yeah, I mean, the sweating the asset is about how we essentially, so we're back to the issue of, as I've said, utilisation of our theatres by our own teams, we maximise. Where it's others wanting it, that's going to be more hard. However, as I've said, the scheduling is, well, I couldn't tell you exactly right now what the utilisation of each theatre at each point is. We'll have to give you that data, but that is about how we then coordinate with lots of other teams and try and coordinate.
It makes something wider than just theatres, wasn't it? It was about actually the utilisation of the the facilities and so on more generally.
Yeah, I mean, obviously, I talked about outpatients.
Yeah, we have got that data as an
Yeah,
organisation.
yeah.
Both for day case, outpatients.
Yeah.
Okay.
Sorry, absolutely. And if I've not answered the question.
No, absolutely fine. So, okay, and I know Kate wants to come in, then we'll probably need to.
I just come in on that point. One of the things we are doing to sweat the assets, if you like, is to make rooms generic and not specific to professions. So certainly with the therapy rooms now, we're making them as generic as possible. So it could be a podiatry clinic one day, a physio clinic the next day, and things like that. So we're certainly, as we develop, all rooms are becoming as generic as possible.
Thank you. Kate?
So on that, then also there's some new guidance coming through some of the clinical networks about less necessity for follow-up appointments. That will allow us to get more first appointments through. So that is being worked through as we speak. Just wanted to come talk about sweating the assets and JAG. Then I think, you can hear the enthusiasm in the team, and they're brilliant because they are a tiny team, but what they're achieving is fantastic. So they're innovative. We're bringing through lots of, the transnasal endoscopy. I think the first community hospital group to use it, etc. And we're constantly looking for the next things, colon capsules, lots of things coming down, all of which will get us to be more productive and better for patients. But I think there's a real theme of fragility of in-reaching services, which is really material and important. So we are constantly offering our space to other health boards who constantly sagely nod and agree, but have no one to send us. And actually we're seeing the opposite. We're seeing lack of, being blunt, SLAs not being adhered to, and it's challenging. So that is a real risk for us, really, and we're trying to grow our own, taking the opportunity where we can find them. JAG, it's been, David made it sound easy. It's not been easy. We've got fragility of the in-reach service, and it's needed to have a very escalated, very escalated conversation, not to get us to the right place. We've had to find a plan B, which should be effective. It will be effective, but I think I'm just highlighting that the in-reach is a real risk to us.
Thank you, Kate. We do need to. Is it a burning point, Steve, or can you make it quickly?
I can make it very quick.
Yeah,
in terms of joining the conversations, that the development of our planned care services will help reduce our out-of-county commissioning spend. So
absolutely, yeah. And Pete, Steve, I just want to echo the point. I think it was you that made it earlier. And I'm very grateful to Helen, because it was Helen's suggestion that we put this on the agenda today, because we knew that we had some sobering matters to talk about, as you say. And I think what this does, it reminds us that, in the midst of all the challenges and pressures and difficult things going on, there is fantastic work happening. Those of us who have the pleasure and privilege of getting out and meeting yourselves and colleagues constantly come back with an extra skip in our step, and I think that is absolutely the case. So please do share our appreciation and gratitude, and we certainly look forward to continuing coming out and learning more. And what may be the case is that we do hold what we call board briefings as well. And it may be that we might want to come back to you where these are just our sessions where we are able to just delve into the detail a little bit more with yourselves and again, learn more about the impressive work that you and colleagues are doing. So thank you very much. Thank you, Mick. Mick's just going to bow out for a little while because he has a commitment to attend to. We
we have about 20 minutes of scheduled time left. So we're going to try to get through the agenda as quickly as we can. We do come to the Integrated Quality and Performance Report. Very, very important report. Let's take it as read. Any additional comments, Steve, please?
Yeah, thank you, Chair. I guess I'd just like to summarise where we are from a performance perspective, because, you know, just to remind, some of the board commitments we gave were to deliver our performance recovery trajectories, particularly for our own provider services. So this is the report to month 4. To summarise, the performance is shown on the cover paper on page 6. And for planned care, we're doing rather well, in part because of some of the conversations that we've been having with Nicola and David just now. So we are delivering the majority of our performance trajectories at month 4. We did have 3 breaches of the 104-week waiters in our own provider arm. Those are 3 orthopaedic patients, and those are in relation to some nerve conduction studies that are due on those patients that we still haven't yet resolved, but we're developing additional capacity to get those patients treated, because we set ourselves a target of 0 across the year. The only other target that we reached in July was for number of patients waiting over 8 weeks for diagnostics, and that was almost the majority of that was due to cardiac diagnostics. And again, we're trying to secure additional capacity, either in county, out of county, to expedite that care for patients. From a mental health perspective, for adults and children's, page 7 summarises the performance of those key services. And again, we set ourselves some challenging trajectories for improvement across the year. We always knew there were going to be a period of recovery for the first 6 months for a number of those indicators. And I guess the one most challenging in terms of being so significantly away from actual target is our neurodevelopmental services for patients. But we heard earlier, we've got some plans in place to address that. From a commissioning perspective, the position is, I guess, mixed. The positive news from a planned care perspective in terms of the overall number of patients waiting over 104 weeks, those are slowly coming down. And by that, I mean patients waiting over 5 years, 4 years, 3 years. But overall waiting lists are still growing as the demand for services continues. Cancer performance is still poor, with all providers failing that target. And similarly, the A&E, a 4-hour wait target that is commissioned across providers, is also way below where it should be, again, because of some of the demand and flow issues that we've talked about. So just in terms of assurance and what we're doing about all these indicators. So from our own Powys perspective, we have significantly improved our oversight, our understanding, and some of the mitigations that we need to make to improve performance and outcomes. From a commissioning perspective, those targets are delivered obviously by providers outside of Powys. They themselves are under a lot of scrutiny to deliver those targets. So whether it be via the own boards of those organisations, or extra infrastructure like in Wales, the NHS Performance Board, and so on and so forth, and ministerial interventions to try and improve performance. So we will see the benefit of those performance improvements eventually come through our commissioned performance services. There's obviously a huge amount of data within the detailed pack, as previously sort of reported in that similar style that we've adopted. And I'm happy to take any questions on the detailed pack. I might need to ask some of my exec colleagues to comment, depending on what the question is.
Thank you. Does anyone have a comment or question? Ronnie, then Robert.
Thanks. I'm just interested in the patients in relation to nerve conduction studies, and I mentioned that to you before, Bert. Okay, you'll correct me if I'm wrong. But I understand that some neuroconduction studies are quite simple and others are rather more complex and perhaps involve the administration of anesthetic. So I'd just like to be clear in my mind what the obstacle is there. Is it just because of delays in the appropriate staff? Or is there some extra element of complexity around it that I don't understand?
Yeah, so I mean, generally there's a national shortage of nerve conduction study capacity. These are three particular orthopedic patients that need that intervention. So it's those both the complexity of the patient, but a fundamental lack of capacity within the NHS for nerve conduction studies at the current time.
It is as a national neurophysiology shortage. Scientists able to do the low-level tests actually.
Low-level tests.
Yeah, so I think it might be a couple of tunnel delays. These three.
Couple of the actual
complicated ones where we, they want a test before they'll operate.
Yeah.
We minimise the amount of testing, and we only send patients who absolutely need it.
Thank you, and Robert. Steve, often when we're talking about commissioned work, we often feel that it's quite intractable. It doesn't seem to change. But in England, they've set up 31 new surgical hubs, and the recent report on that is that for things like hip replacements and cataracts, these are called high volume, low complexities, that they've been able to undertake 22% more operations than they were last year. Are there any plans within Wales to do something similar?
So yes, Robert, there are. Llantrysant Health Park, there's a business case that is being worked upon to do that. Llandudno in North Wales is also being developed as a high volume, low complexity. And of course, we're trying to do that. We're trying to run high volume, low complexity lists ourselves, how we do for cataracts within Paris. A number of the big acute providers in England and Wales are developing those same day surgical facilities. Hereford, they literally just opened one a few weeks ago, and a number of Parish patients have already flowed through it. So despite some of the workforce challenges, Robert, those schemes are getting off the ground and are making a difference to waiting times.
Yeah, and absolutely, that is optimal use of staffing by having your staff on one site, and people do have to travel a bit further but get the operation much more quickly. Then that is absolutely the model that I think most people would support as well. We have looked at so GERF have highly promoted or heavily promoted the work, and we are ideally suited to it. We've had a really positive conversation with neighbouring health boards about trying to get high volume, low complexity through our theatres such as orthopaedics, and lots of trials. But actually it comes back to InReach. Unfortunately the capacity and the staffing within our InReaching and our neighbouring health boards is such that we haven't been able to get any of them off the ground yet. The work that we're doing, such as ophthalmology, we're enhancing, but we talked about hernia lists, orthopaedic lists, but they just haven't got staff to send them. So but we just keep the conversations going in the hope that we will manage to kickstart it.
Thank you very much indeed, and thank you, Steve. And just before we come to the recommendation, can I just say we often, we often express appreciation for the reports themselves, the finance report and how it's presented. I just think the way this report has been developed has been really, I think it's an absolutely excellent summary at the beginning that then, as independent members, helps to signpost us to bits of the report where we might want to just go and check that detail or look into that. So that's really appreciated. Thank you. So we're asked to discuss the content of the report and to take assurance that the Health Board has appropriate systems in place to monitor performance and respond to relevant issues. I'll assume that people support the recommendation. Please indicate if you don't. Thank you, that's supported. So we stick with Steve. Again, we take it as read, but the Q1 annual delivery plan.
Thank you, Chair. So this report deals with the progression of our submitted plan to Welsh Government, but also, most importantly, it captured the actions that we said we would deliver as a board, as individual execs, to deliver our plan for 24-25. That the cover paper clearly emphasises that the plan itself is still not approved in that broader piece that both Hayley and Pete have commented upon in terms of our actual plan being unsupportable. The plan itself then is drawn upon the performance of our actual actions against those that were planned to be delivered in the first quarter of this financial year. And we've gone through our normal process of testing and challenging where we are against those actions with each individual executive director. And also we've developed the delivery confidence as to how we think each of those actions will play out at the year end. So there's a fair bit of detail within the report, but I guess I'd like to draw your attention to page 3, the pie charts of the detailed pack that gives that overall summary of where we are across all those factors that we're seeking to deliver. Those little pie charts summarise the actions that we've completed that are either on track, are either at risk, behind schedule, or not due yet. And you can quite clearly see against those high level indicators how we're getting on as a health board. And I guess it's important to triangulate what we said we would do in terms of actions and deliverables, with then the cost of doing so from a finance perspective, the amount of staff that we've employed, and the quality and the performance that's been delivered as a result of that joint endeavour. So I just wanted to draw that out really in terms of joined up narrative in terms of how we're getting on with our submitted plan. And that overall pie chart in the bottom right hand corner does show that there are some tasks that are behind target, and that's largely due to either recruitment delays into a number of key posts, some delays on digital projects, or delays in pathway development.
Thank you, Steve. Does anyone want to comment on this report? No? Okay, thank you. So we are asked to consider the report ahead of its submission to Welsh Government and take assurance that there is a process in place for monitoring progress against the plan. Again, I assume there's consent in the room to support that recommendation. Nobody's indicating to the contrary, so that's simple. We come to the corporate risk register, and over to Helen. Thank you.
Thank you, Carl. So the board will recall back in July, you approved a new set of corporate risks. That was after some quite significant work that had been done to revise those against our current annual delivery plan, the integrated plan, but also the longer term strategy that we have in place for Powys. So I'm very pleased to be able to provide you today the full new corporate risk register. This is a really significant part of our board assurance framework. That again, ongoing work is in place to develop how we present that board assurance framework to you. And that includes how we present and visualise, I think, some of the content of the risk, but also some of the challenges around the controls and the assurances that may be in place. So that work is ongoing. What you have got here today, though, is the full corporate risk register and a couple of enhancements. We've absolutely embedded the board risk appetite in the new template. We've also made sure that there's an enhanced section around the level of assurance that can be taken against each of the controls that are in place. As always, when you implement new systems and approaches, there is some ongoing work to do to make sure everybody's understanding and application is consistent across that. But I'm really pleased that the board can see that level of information today. So just a brief reminder, the corporate risks are and we just to say we deliberately moved corporate risk to follow the finance and performance reports because the corporate risks are a direct correlation of what is it that might knock us off our feet in terms of our strategic delivery. So there were just a couple of points to draw out. We've enhanced the cover reports and welcome any feedback that you might have on that. Our board committees play a really significant role in doing more deep diving on behalf of the board and seeking evidence against each of the risks that are relevant to those committees. So we've just highlighted in the cover report as well which risks are aligned to each committee and they're reviewed on an ongoing basis. And Jen, you made a point earlier, and I think in the last meeting as well, just that there are more risks aligned to the Delivery and Performance Committee for the reasons that we discussed earlier, and just to say that we're keeping a very active review of that as well. There are two other particular points I just wanted to draw out. You asked us in the last board to go away and have a look at risk 006 in relation to workforce. Deborah Wood-Lawson is the SRO. That's she's obviously away today, but that's been done from her team. We've also had a look at that in the executive committee as well. We think the risk story is still right in the context of the risk and the risk descriptor, and it's very much focused around can we, to a large extent, staff our services, and accepting that some of that staffing comes through bank and agency, and that has a different issue, which we talked about earlier in the meeting. In the context of being able to staff it, we still think that sits relevant. So looking across the risks, but also down into the workforce risk, that's the recommendation we've come back with. But I think, Jen, as the chair of Workforce and Committee, that would be a further issue that we want to explore when we look at the risks overall in the committee context. Just the other thing, Carl, sorry to draw out, we are recommending the inclusion of a new and additional risk today. That's risk 012. It's in relation to national digital programmes. Just because of the nature and sensitivity in there, we're recommending that goes into the in-committee session of the board. But for absolute clarity and transparency, the summary of that risk is provided in the in public papers, along with the two other risks that are considered in committee. So I hope that's a helpful introduction. Very much welcome any comments or questions.
Thank you. Robert, as Chair of Audit and Risk, I just wondered whether you'd like to offer a comment or anything from either your perspective as Chair or the perspective of your committee.
Just to say that we appreciate the way in which Helen set this out and partitioned the work. I think that's makes it much more manageable, and it also means that we have to have ownership of risk. So I think that's an improvement. The list is a long one, but I think it's a beneficial move.
Please, Ron.
Thank you. I think this is excellent, the way that it's been set out. I can see that an awful lot of work has gone into it. So from my perspective, I'd just like to acknowledge that. But I'd also like to say, and you know what I'm going to say, I think there is a document that needs to sit in front of this, which is actually a summary of the risks in a way that we can easily see on one sheet of A4 what's going up, what's going down, and where the principal problems are. Thank you.
A risk gap. Yeah.
I absolutely agree. We're working on that as part of the board assurance framework. I wholly agree with you, Ryan. Thanks for the comment.
Thank you. Please.
Yeah, thank you. Just in relation to the new risks, really, around the national digital programmes potentially not meeting Paris requirements. I think that's for the initial discussion. It may be elements we will be able to bring it out within committee, but you mentioned earlier about just one example, WCCIS, where there are a number. And I think one of the issues in that initial discussion for us in committee is to understand how we manage a risk when we actually don't own the action to be able to mitigate it fully, because that's being led in a national programme. And I think that's the first exploration before we decide where we would eventually land that risk. It may be an escalation, for example, to a national programme board to manage some of those elements of risk.
Thank you. Okay, so we're asked to receive the corporate risk register as a full and accurate record of the Health Board strategic risks, and to take assurance on the controls and assurance on the controls that manage strategic risks, and that there are actions to address the identified gaps. And as Helen said, we will come back to the specific additional risk in our in-committee discussion later. Again, please indicate if you don't support that recommendation, and therefore that's supported unanimously. So I'm just looking at the clock. I know that we've got our vaccination colleagues possibly waiting in a room to vaccinate us, which is and then we have the vaccination report to do. Mez, do you think we could? Is it possible to deal with this quite quickly so that we can finish? I don't want to keep colleagues waiting unnecessarily. Just looking for your steer as to what you.
I'll be fine and free, I believe. Yes.
Yeah. Okay. Please. Yeah.
Okay, so I've got two sets of papers. The first one is the winter respiratory vaccination plan, which is flu and COVID vaccination. So the paper sets out the deployment plan and then blended delivery of model across the powers providers. Members will be familiar with the deployment plan from last year, but the main element is obviously to protect individuals, to reduce circulation of flu and COVID in the community, and obviously to support the resilience of the NHS. So I'll take the detail of the paper as read, which is to say that I'll be taking regular updates in terms of progress of uptake to execs and to PPH committee in November. And as always, happy to take any questions.
Wow. That's thank you. That's much appreciated. Does anyone have any questions or comments on this report?
No. Just to say that Mez, we're going to be particularly interested in the take up by staff as well and focusing on that.
Yeah. Please, yes.
So just a quick one, Mez. Reference to only 6 out of the 16 GP practices being involved with the COVID vaccination. When we had a tour around yesterday, we spoke to medicines management. They were saying that the procurement arrangements around the flu vaccine are changing. I think I'll pick that up correctly. That will have potentially issues for GP involvement in the flu campaign. Just to what extent are you concerned about the involvement of primary care in the programme?
Yeah. So for the flu programme, all GP practices participate in the flu programme, as do all pharmacists. So there is change coming from 2025-26. Currently, providers order their own vaccine and Welsh Government having discussion. And I believe the announcement has been made around change in procurement or central procurement, which has happened for COVID over the last few years. Really, so we'll be moving on the next few months as more information becomes available and work with primary care. So that's in the planning for 25-26.
Okay. Thank you. Yes. So in terms of the recommendation as regards winter vaccinations, there are a number of things to note within the recommendation. I won't read them all out. I think the important thing is that for the last bullet point, that we take assurance that the Health Board has in place an appropriate plan for the winter respiratory vaccination programme, and that delivery will be continually monitored and adapted to maximise uptake. But I will ask for your support, please, to the whole composite recommendation. That's supported. So RFP, please.
Okay, yes, thank you. So the purpose of this paper is to inform members of an introduction of a new programme, which is the RSV programme. Members might recall last winter, or the last few winters, we've had high rates of RSV, particularly for children, and a number of incidents, and indeed acute departments surging their services to meet that sort of demand. At the beginning of the summer, the JCVI committee recommended a new vaccination programme, which will offer protection to those obviously most at risk. 3 groups in the eligible cohort. So the first one is pregnant women at 28 weeks, and that's commencing from this month. And obviously what we hope is with the impact of that programme will be to reduce RSV in babies. Then the school delivery team of the health board are proactively offering that vaccine, and also they'll be doing a catch-up as well for those pregnant women between 28 weeks and 34, 35 weeks currently. So they have a bit of a backlog of the next 3 to 4 weeks, and then it will be a routine program for 28 weeks of pregnancy. And the second group is 75-year-olds. As individuals turn 75, they will become eligible for the vaccine. So they call this a birthday vaccine there. So the blended delivery model there for between GP practices and the vaccination service. And then the third group will be a catch-up for those already 75 to 79 days, 365, but yes, nearly 80 years age. And that catch-up will operate in the spring of next year. So I mentioned earlier that the decision for that programme was made at the beginning of the summer. So my thanks really to staff across the health board and for those participating GP practices for quickly really what I would call developing a deployment plan element. Really, it's very much building the bus and driving the bus at the same time in terms of impacts of that sort of service, to just to provide assurance that, you know, planning and delivery is underway, and clearly we'll be monitoring the uptake of that programme. Thank you.
That's a metaphor.
Yes.
The building and driving at the same time, taking all the time to drive. But thank you very much. Does anyone want to? Please.
Just huge thanks to you and the team for the flexibility and agility of your work around this. It's really hard to plan these campaigns. There are short windows to prepare quite often as well. And I just think people might not know this, but our midwives actually vaccinating is quite unique in Paris. So huge thanks also for the range, all professional groups of engaging with us.
Yeah. And so again, in the recommendation, there are a few things to note, but then the last bullet point is that we take assurance that the health board is planning for an appropriate RSV programme for the 24-25 year. I can see people nodding heads and no one indicating that they don't support that recommendation. So that is supported. Thank you. Katie Blackburn, the Regional Director of PLIS, who normally attends our board meetings, isn't with us today. She sent her apologies. So I'm going to suggest, with your agreement, that we put the PLIS report as part of the consent agenda, unless anyone has any burning matters that they would like to raise. And therefore we receive that agenda, that report, as alongside the other items on the consent agenda under item 5, most of which are there for assurance, all of which are there for assurance. And so again, I just I assume that everyone is happy to receive and those reports under the consent agenda as sources of assurance. Thank you. Is there any other business? I don't know of any. No? In which case, that concludes our business in this meeting today. We have our next, if you like, what was the scheduled board meeting on the 27th of November. However, as we have noted earlier in the meeting, we do have the additional meeting on the 10th of October to deal with the issue of the proposed temporary service wages. But for now, thank you ever so much to everyone for who's made the arrangements, contributed, and so on. And I'm, it's been great to be together, hasn't it? And and to actually be face to face in this room. So thank you. Yes, thank you, Helen. Helen's just reminded me that we will be going into an in-committee meeting after our lunch break, and therefore we do need to pass a resolution and that is that representatives of the press and other members of the public should be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest.